Darren Griffiths from Audit Wales is also not able to be with us, and nor is Alan Davis, the chair of the Aneurin Bevan Community Health Council. But I'm glad to say that Gemma McHale, the Chief Officer, is with us, and Stephen Cheney from Internal Audit is also in attendance. I don't think, Richard, that there are any more apologies, are there?
No, Chair, I haven't received any others.
Thank you. Could I ask if there are any declarations of interest arising from any of the issues on the agenda today? No? Thank you. Could we take the minutes of the last meeting? Are they a true and correct record?
Yes.
Yes, thank you. We have some matters arising. Richard, can you take us through them, please?
Yes, Chair, we have on the action sheet, we have 3 items, all for our Director of Finance. We have a board development session to discuss the implications of the Health Board's plans to deliver the strategy care closer to home, and that's scheduled for the board for the 8th of September, board development session. The financial reports and some in terms of the actions there, the outcomes, summary of savings is included in the board finance reports. And then we have the performance report about reflecting elective demand, and that's scheduled for a board development session as well. That was scheduled for August this year.
Thank you. Are you content with the actions as detailed, Judith?
Yeah, thank you, Chair. I had a matter arising from the minutes that's not on the action log. When you are ready, I can contribute on that.
That'd be helpful, thank you. Well, would you like to do that now?
Okay, thank you. It relates to the minute relating to the regional work on the development of the vascular service, work that we're undertaking with our colleagues in Cwmtaf, Morgannwg and Cardiff and Vale Health Boards. The minute updated board members last time on the progress that had been made and indicated the possibility that the business case would be coming to the board in July. Just to update, that work is progressing. But as board members will have realised, the business case isn't on the agenda today. At this moment, I can't give an indication of when it will be coming forward to the board, but just to give assurance that the work is progressing at pace and engaging all colleagues who need to be involved in that. Thank you, Chair.
Thank you, Judith. Are there any questions in respect of that? Okay. Any further issues arising from the last minutes that haven't been detailed on the action sheet? No? Thank you. Item 1.6, the report on sealed documents and Chair's actions. Richard?
Yes, Chair, this is one of our standard reports about how we've dealt with sealed documents and Chair's actions during the last period. You'll note that we've had 6 documents that required the use of the Health Board's seal during the period, and a number of Chair's actions as well, 5 Chair's actions that have been agreed. The items of the sealed documents are from May until July, a service level agreement for Fly and Start, health visiting and speech and language therapy services, a call-off contract for the breast care unit at Ysbyty Ystrad Fawr, a contract for the sale of freehold land with vacant possession in Caldicot, some service charge caps, and the full business case for a satellite radiotherapy unit, and at a lease for support of a house and mental health division in Betws in Newport. And the Chair's actions are listed as commission of facility at St Joseph's Hospital, the installation of a patient call and safety alarm system and building management system by Honeywell, ophthalmology outsourcing to Practice Plus Group, and a platform enterprise subscription for Attend Anywhere. That's the maintenance and support. So the board has asked that they endorse these complying with the standing orders.
Thank you, Richard. Are you content to accept and adopt this?
Yes.
Thank you. Chair's report. Very briefly, in addition to the usual responsibilities that I have, I need to advise you that I have met the Older Persons Commissioner during this time for her to confirm her priorities for the next year, which include chronic disease management, dementia and mental health, age-friendly communities, isolation and digital inclusion. She's very enthusiastic indeed to work with the Aneurin Bevan Health Board, and therefore it will be helpful to invite her to a board briefing so she can outline her proposals for the future more clearly to us all, which was helpful. We've had a meeting of chairs and chief executives with the minister to welcome her and to discuss with her her ministerial priorities, which you will all have seen in the letter that came out from her and Andrew Goodall. We also discussed, in particular, population health and well-being and the importance of prevention across the range. And I know that she will be very keen to see how we progress building a healthier Gwent in this area. She had not realised that we'd done our own report, and she was really enthusiastic to see that and to see how we progress. So that was very positive. I've also had meetings on behalf of chairs with Welsh Government officials on the next stage for the white paper on social care. As you will have seen, they've had a number of responses to their consultation, and now they're putting the very disparate views into a matrix and are going to start to establish some working groups to take this forward. At the moment, I haven't yet heard from her, but she seemed to be enthusiastic to take up that proposal. We've had a number of meetings. Develop the next tranche of executives and the next level of management, both clinical and non-clinical in Wales, and that seems to be going well. It's picking up pace, so that was good. And finally, I had my appraisal with the minister a couple of weeks ago, and I await the written response, but it seems to be positive from where I was sitting, and Judith joined us so that she could see whether or not we worked as a team, I think. But that was quite helpful, and she was very, very pleasant to us. So that's basically what I've been doing in addition to my normal work. Are there any questions? No, thank you. Could we move on then to 2.1, report from the Aneurin Bevan Community Health Council, Gemma?
Good morning. Thank you, Chair. Hi, everybody. Thanks for inviting me to present again. I'm happy to share our July report with you, which is shorter than the first one that I presented a couple of months ago. But we've got a couple of items of activity that we hope to share with you, and it follows on from one of your members' questions previously about GP access. Items 1 and 2 in the report really go hand in hand on GP access and the virtual appointments platforms that are being used to give access to people in a remote way to not only GP access, but also secondary care appointments as well. The first report that we've recently published, which the Health Board have now responded to, just reflects on a long-standing survey that we have published on our website and in other means. But we heard more frequently from people from the start of this new year. So over the last 7 months, you can see that we've heard from over 1,000 individuals who wanted to share with us what they think about access to GP services at the moment. What we did note was a large percentage of people were empathetic and sympathetic to the extreme pressures that happened and the fast changes that had to happen in order for GPs to be able to still provide a service. But the one thing that we did pick up quite strongly was that the use of remote appointments can often be all day sort of slots, which is okay when people have an appointment, but then they're unable to even put their phone down or their iPad down if it's a video appointment, and be able to get on with their day-to-day activities. So that was one very, very strong theme that came out of GP access at the moment. What we also heard was that, again, people did understand the pressures on staff, but what was shining through was people referred to staff as being impolite and unhelpful, but I think that's just reflective of the current climate the staff are working in, and I think some of their tiredness and frustration is potentially showing through. So people were quite clear that they feel that the pressure is on staff, especially when they're speaking to them over the telephone. A number of people raised in both the GP access and the virtual appointments report that the e-consult form isn't necessarily fit for purpose for their needs. A report will be coming out from us shortly to do with access to healthcare for people who are deaf or hard of hearing. And e-consult also shone through in that people couldn't book translators through e-consult. Some of the questions weren't relevant to their conditions. And I've had this discussion with a number of Health Board colleagues, and I understand that e-consult is a platform that this NHS didn't build. It's a platform that was offered to the NHS as an external provider. So I appreciate that you're very limited in how you can adapt e-consult, but this was very, very strong feedback from the public in that regard. And we also noted that a couple of people responded in respect of the changes that were made to their practices throughout the pandemic, and we recognise that each practice has its own challenges in terms of GP coverage per population, small single-handed practices versus large GP cohorts or surgeries that have branches. So lots of people found that there were variants in access to GPs dependent on the size or the ability of their practice. But we work very closely as a CHC with primary care to make sure that website messages were very clear, that if urgent changes were needed, that the population was engaged with as soon as possible, so as that people knew if a branch had to close at very short notice for staff and resource concerns. So in terms of GP access, we're not surprised by the feedback that we've received, but it was very, very clear that the population on a monthly basis now through our regular monthly feedback briefing are raising GP access more and more, particularly in terms of frustrations around access to face-to-face appointments, and them believing and people feeling that the threshold for face-to-face needs to be a lot lower. So I think that's a fair reflection of what people are feeling at the moment. In terms of the virtual appointments on its own, what was really encouraging to hear is that people do see the value of the virtual approach remaining as a supportive measure to face-to-face. We only heard from a small percentage of people that had access to remote appointment, but again, it came back to it being an all-day appointment. Some people were really concerned about having to send photographs to an unknown email address, within their practice. And, you know, a lot of people told us that, you know, they couldn't take clear pictures on their own phone, never alone send one to a generic email address within their practice, and not know who might pick that up or when. But what we did see was that people do see the place for virtual appointments as a complement to face-to-face.
Should we pause for a second, Gemma?
Yes, thank you, Chair. Yes.
Thank you. Gemma, first of all, thank you very much for producing this, because I think it's a really it's really key message for the Health Board, and it was me who asked the question last time.
Yeah.
And so I'm really pleased to see the report. And I'm like you, not surprised, but I am a little bit disappointed. But I guess really what I wanted to say was more of a comment than a question, because I think that this gives us the information that we need in order to be able to find a way to make improvements in this area. Because if it's highlighted, then it's something that we can look at. And I suppose that's really my point here is a question around how do we as a health board take this forward in order to get better access for our patients, so that they don't feel frustrated in this way. And I just think that your report has really highlighted that. So that's what I wanted to say. Thank you.
Thank you.
Thank you, Pippa. We'll come back to the answer to that in 1 second when I've had the other questions. Tej and then Rhiannon.
Thank you. My comments were very similar in as much as I think this is a very valuable report, and the questions that you've asked the public are exactly what I would like to see. It's really drilling through to what actually matters to individuals. So if they're called back, if they have to hold, you know, they have to keep their entire day free, that kind of thing, because that really makes a difference between somebody being able to access our primary care services and not. So thank you for that. And my question was very similar in as much as how, not for you, Gemma, but we will talk internally about how we take forward this learning. I'm sure that colleagues within the Health Board are very open to the learning, but practically, what is it that we are going to do? So it's really assurance to you that that we as a board are very committed to that.
Thank you.
Thank you, Tej. Rhiannon, do you still wish to comment?
If I may, yeah, thank you, Chair. Like colleagues, I think important to highlight the value of this report and our ongoing relationship with the CHC in terms of this particular engagement piece. In terms of GP access particularly, we have responded, as Jem has indicated, to the helpful report outlining some of the actions that we will be taking. But just for assurance, this has been picked up by independent members as part of the Patient Quality, Safety and Outcomes Committee, and is agended for the next meeting, and the director and members from the division will be in attendance to go through the report, our position within primary care and the actions being taken. I think Gemma has highlighted there the issues that are faced and the public understanding of that, which I think is important, but probably just to flag that primary care has seen up to a 20% increase in activity and demand based on pre-COVID levels. And this is against a backdrop of staff absence, vacancies. We've got some issues with practice sustainability and challenges associated with that. And like many areas, and again, as Gemma alluded to, the pandemic fatigue and staff exhaustion. So I think it's important for us to take all of that in the round, but recognise there is a positive response from the Health Board in relation to the engagement work and the patient voice, a recognition that we need to improve our communication and some of the processes that have been put in place, and we will be sharing that at the committee at the next meeting, and we can clearly provide an update to the CHC on the ongoing work. Thank you.
Thank you very much, Rhiannon. So that I think is very encouraging, and I'm glad this has been picked up because it is coming up an awful lot at the moment. So I think that will be extremely helpful. Thank you. Gemma, do you wish to continue?
Yes, thank you. thank you, everyone. It's really encouraging that the report has been so well received and that it is going to your various committees for working through. So thank you kindly. On item 3, we're continuing to focus some attention on ambulance handover times to the emergency department in the Grange, and the pressures that this is impacting on the community and people's waits for an ambulance. I have written to the Health Board recently around 3.1 to 3.4, and I have received a reply, so thank you. I will be taking the reply around these 4 items to our executive committee tomorrow, so they may have some follow-up questions, which I'm sure you'll be in a position to help me with if committee have any further questions. But I'm very grateful to the team for implementing weekly meetings with the exec team with myself so that I can understand the ambulance handover times and the pressures within context, because whilst I monitor data, that doesn't really give me the true picture for the person that's waiting on the back of the ambulance, waiting to go into the ED. So I'm really grateful to the team for meeting with me every week, just to give me some context and some of the ideas and initiatives that are being tested in order to see sustainable improvements. So we will discuss that tomorrow further at our exec committee, and I hope to come back to you with some follow-up questions.
Thank you, Gemma.
Thank you. We're just about to write a report on our access to adult mental health inpatient services. And again, I just want to thank the Health Board for supporting us in this virtual piece of work again. We approached this this project in a similar thread.
Oh. Gemma, I think you've frozen.
It appeared to have, oh, am I back? I'm sorry, I just went on hold for a moment.
Yes,
thank you. We're just about to write the report, so I'm unable to draw any key themes for you at the moment because we still have one ward awaiting to be visited, and it was felt in that instance that this ward would benefit from a face-to-face visit from our members. So moving on to our accompanied visiting approach, I had a discussion with Rhiannon and Tanya Strange about agreeing an approach for our CHC members to return to some form of face-to-face visits to hospital wards and departments. This is taken off like wildfire, and lots of our members are very interested, and the person-centred care team has been wonderful in offering a nominated officer to support our members, not to engage with people on the wards as part of the person-centred care team, but to be there as somebody that's done a visit in the current climate in COVID and moved from patient to patient to speak to them in a safe way in line with your infection control. So a member of the person-centred care team will join a group of our members during a pilot, which we're calling 7 days in ED in August. So we're hoping that a team of our members will be in the emergency department every day for 7 days, through the visiting periods, to speak to people in green areas, in safe areas, with a member of the person-centred care team on hand to give them practical guidance on being safe and what to do if they've got any concerns. So we're moving forward now to reintroducing our face-to-face visits, and I'd just like to offer thanks to the Health Board for supporting us to do this. We're the first one in Wales again to introduce CHC visits to hospitals. And my SMT for CHCs has picked this up, and I've shared the project learning with other CHCs so they can hopefully introduce that with their health boards too. So thank you kindly again for that.
Thank you,
and
Rhiannon.
that's it for me, Chair.
Thank you.
Thanks, Chair, and thanks, Gemma. I'd probably just come back to that last point first. I think it's been really pleasing for us to extend that CHC buddying work, which has been invaluable throughout the pandemic period, and we've received reports both at the board and at the Quality and Safety Committee. It'll be really positive to see the physical visits happening, which are from the beginning of August, and we'll closely monitor that to ensure the safety of obviously the CHC CHC members, patients and staff during that time. We'll be monitoring that in line with the COVID position across the Health Board and our visiting framework. So just for assurance for board members, but really good to see the physical visits now being reinstated, or being in a slightly different way, and we're pleased to work with the CHC on that. And if I may, Chair, I just wanted to pick up on the issues outlined in the report in relation to urgent and emergency care. Of course, we've got a paper later on in the agenda, so I won't go into too much detail there. But the CHC have highlighted issues in terms of and concerns in relation to stroke services, the transfer and discharge lounge and maternity. As Gemma indicated, we have provided a comprehensive response on the actions that are being taken across the Health Board, and just confirm that we hope to have given assurance on the specific matters, but naturally welcome any further inquiries from the CHC to provide further assurance on the work that we're doing. Gemma will know that the approach and the pressures that we've currently got in relation to urgent and emergency care are one of our top issues and risks across the Health Board and for our public and population. And the paper later will outline some of the work that we're doing to mitigate those risks. Thank you.
Thank you, Rhiannon. Paul?
Just to say, I mean, the CHC have an incredibly important role to fulfil as the voice of the patient and the public. And I just wanted to say to Gemma, sorry, the report, I think, is a very good one. Equally, I did want to say to Judith and the team, what is important is that we're in listening mode. It's been a very difficult period indeed for staff and for the public and for society in Wales in general. And I think it's so important that, you know, where there are messages and where there are things to be learned, we can pick up on that. But I've just, you know, been greatly encouraged by what Rhiannon has said in terms of the way that we are working with the CHC to look at these problems, to look at them pragmatically, and also to look at them realistically, but to listen to what patients are saying and the public is saying, and then acting on those. So I think there's a very good professional working relationship between the board and with the CHC, and long may that continue, because I think it's important we are listening. And we are hearing and we are acting on some of the comments that have been made, particularly about the very difficult area at the moment, I think, of GP access, because suddenly, as Rhiannon says, 20% extra numbers is a lot of extra work there, and I think it's important that we are as supportive as we can be of our staff, as well equally of you know, working for the staff, working with the public to get the best service possible.
Thank you, Paul.
Thank you.
Are there any further questions to Gemma? If not, thank you very much. I endorse the comments that have been made by the board about the sound working relationship and your very honest approach to working with us, and the invaluable work that you do in highlighting additional patient stories so that we can take them into account when delivering our care. So thank you ever so much to you and all your CHC members for the work that they are doing. Thank you.
Thank you.
Can we move on to items for decision and start with the pet business case, please?
Yeah, good morning. I'm taking this one, Anne.
Thank you.
So hopefully you've all had an opportunity to read the paper, and hopefully this is reasonably self-explanatory. So position emission tomography, and I'm going to call it PET scanning throughout, so I don't have to keep referring to that mouthful. Essentially, what we're looking for here is a letter of support for the national programme to endorse the programme business case. I thought I'd start with trying to find a simple definition of PET scanning, because there wasn't actually one in the paper. So PET scanning is a type of scan where radioactive dye is injected, so that not only does the clinician see an image, but also understand how well cells are functioning, because they're able to see where that dye builds up. So the dye has the same qualities as glucose, which is consumed at a faster rate by cancer cells. So you're able to get an image, but also see how well cells are functioning. So I'm not a clinician, but hopefully that's a reasonable, simple explanation to explain what a PET scan is. I needed to do that myself. So this is part of a national programme of work, and increasing indications of PET scans are happening right across the UK, and it's becoming more and more of a normalised technique in cancer diagnosis. Currently in Wales, we are not well served by PET scanning. So we have one machine in Cardiff that is run by Cardiff University in partnership with Cardiff and Vale Health Board, and 2 mobile devices. And we're more or less entirely reliant on the independent sector for PET scanning. So this PBC is looking for £24 million of capital to develop 4 scanners across Wales and the supporting infrastructure that goes with those services. So it's not just about the scanners, but also ensuring that we have the production of the radioisotopes that are needed for the dye that goes into the process. There are a lot of benefits to this programme and a lot of benefits in terms of our ability to access what will become an increasingly normalised technique, both for cancer and increasingly a wider range of indications as well as part of a diagnostic tool for the service. What we also recognise is that by bringing this in-house into NHS Wales, it does start to reduce the overall cost per scan. So in the programme business case, currently it costs us about £935 per scan, which should bring it down to an average of £729, so saving about £200 per scan, which is very significant when you look at the indications of future use of this technology. So set out in the business case is that actually by bringing the service in-house in this way, you've got about 6.6 million of cost avoidance by bringing the service in this way. So I mentioned there's also increasing use of the application, but also huge research potential. So because of the type of technique and the information you're able to get from it, it's really important and really useful for research purposes and an opportunity to generate research income on the back of that. So if you're content as a board to support this, the next steps would be then to move through the process of the business cases for the individual scanners, with the first being looking to replace the scanner in Cardiff by way of a business justification process, and then following on with the outline business cases and full business cases for 3 further scanners. So that's all I was going to say by way of introduction. Happy to take any questions.
Thank you very much, Chris. Paul, and then Tej and Shelley.
I think that Chris has put it exceptionally well. It's a very, very good report. We've been asked to support an All Wales initiative, and I would give this 100% support. I think it's incredibly important, particularly at this time, to sort of invest in these particular schemes and the particular project. So I'm, totally in favour of and supporting this project.
Thank you, Paul. Tej?
Thank you, Chair. Again, I think it was an excellent report. It was really I think it was very well set out and understandable, so thank you for that. My question is around the risks relating to the supply of the radioactive isotopes and dyes, and not detail, but are we confident that that is something that we can overcome? We know from the last couple of years that the supply of things that are outside of our control can actually be very limiting. So I'd be interested in that risk and how we would manage it.
Thank you, Tej. Chris?
Yeah, so in terms of that, I touched in with the programme team last night for reassurance on that one. So the manufacturing of the isotopes and the dye is part of the business case. So within that, there's a number of opportunities in terms of the manufacturing work in Cardiff, in terms of building resilience in that to ensure that we do have confidence in the supply. And that is part of the programme business case. So we are really reassured on that. We also have opportunities with contingency suppliers in Birmingham and Bristol, which have been used in the existing structure. So we know that as well as increasing investment and developing our own ability to manufacture these in-house, we've also got that resilience in the supply chain with the business continuity arrangements with Bristol and Birmingham.
Thank you. That's exactly what I was looking for. Thanks, Chris.
Thank you, Chris. Shelley?
Obviously, I support this as well. I think it's great, a great move. Can I just ask one thing, though, Chris? With the mobile scanners that are currently in place, will they not be used at all? So I say only, but we'll have the 4 fixed scanners. I just wondered. I wasn't quite sure about that.
Yeah, my understanding is the plan is to phase out the mobile ones. Okay. They're entirely run by the private sector. Right, okay. So this is a replacement programme that takes off our reliance on the private sector.
Great, that's lovely. Thank you very much.
Are there any further questions to Chris? Could I just ask Chris, what sort of process is going to be used to determine where the fourth scanner might go?
Yeah, so that's with the National Programme Board at the moment, looking at the options appraisal around it.
Right.
So they're doing the work in terms of the options appraisal, and then it will come back through. It will come through to the collaborative executive group ultimately as the governance process for that.
Right. Thank you, Chris. So, given the discussion that we've had, are we content to provide a letter of support for this case? Yeah.
Yes.
Thank you. That'll be a big move forward. Good. It's well worth the resources, I think. Thank you. Could we move to YYF and the business case for approval? We have, of course, discussed this in detail at least twice. But Chris?
Yeah, so I'm hoping that Andrew is joining the call for taking us through this paper, and Andrew will talk about take you through the detail in terms of the process around the case and the next steps. I know he's going to have Glynis on hand as well, who's the general manager for scheduled care, in terms of any operational questions.
Good morning.
Andrew?
Yeah,
morning, Andrew.
Morning. As you've just said, the business case, this is the third business case that's been to the board. Strategic outline case was approved back in 2019, the outline business case in 2020. The full business case is the final stage, you'd be glad to know. And if approved by Welsh Government, construction will start in October of this year, with about a 1 year construction period. Not a great deal has changed since the OBC was approved. The capital costs are now 10.67 million. They are slightly lower than the uplifted OBC cost with inflation added. But we had to do a piece of work over the last few months to reduce the capital costs down. They were quite a bit higher than the OBC, and I think if the FBC had gone in higher, it would have been more problematic for Welsh Government to approve, or at least approve quickly. So we have a project that is more or less agreed in principle with shared services and Welsh Government, subject to the business case being received. I think the case for change is well understood by most, if not all. We're attempting to move services from more than 2 locations into 1 at YYF, which will effectively become a one-stop shop. The revenue costs are not that different from the OBC, but there is a revenue consequence, which the division will need to find from within their resources. And I think they can talk to that if they're on the call. As the case with many business cases, we struggle to identify real benefits. But this one, and I've summarised them in the paper, has some real measurable clinical benefits that I think if they can be attained after this building is built, it will be real progress that will justify the capital investment. A gateway review was undertaken back in May, just before we started to draft the FBC properly. Some comments were made. It was rated as amber, which, to be honest, I don't agree with that. I think it was amber green. But anyway, it was amber. We've addressed the points in the FBC, mainly related to revenue costs and governance. So I don't think there are any issues with that need to worry the board. I think that's probably about it, really. I've already outlined the programme. So if we've allowed 2 months to Welsh Government to scrutinise the FBC and give approval, and hopefully we can start construction in October.
Thank you, Andrew. I have a number of questions. Shelley, Paul, Pippa and Tej.
Thanks, Andrew, for that. I just wondered if there is someone on the call. It was just in relation to the savings associated with the development, and obviously need to be found within the existing scheduled care allocation. And I just wondered if you could give us any ideas about how you thought that would be achieved.
Yeah, I think Glenys and Julie are on, Shelley. So,
Glenys?
Yeah, morning all. We've looked quite carefully at this, and I think one of the things that position we're in currently in terms of recovery for COVID, we are going to be looking at additional capacity for some time to come to us to get recovery. So what this will do, it will free up, it will reduce within the service itself a number of waiting list initiatives that are already happening and we're paying for to meet our breast cancer targets. So those will no longer be required once we're in the unit, plus the space that's freed up by the moving out of the other sites and just having minimal number of procedures that need to be done outside of YYF through theatres will allow us more bed capacity and theatre capacity to put into our other specialties, which will come up through our demand and capacity. So the savings will go into sort of the breast unit, but we will obviously look through our IMTP plans going forward to fund that capacity.
Thank you, Glenys. Are you content, Shelley?
Yes, that's fine. Thank you very much.
Paul?
I mean, I think, it's one of these once in a lifetime opportunities, really, where a change can make a significant difference. And with regards to the additional capacity, which is what I was going to touch on, but you've answered that, Glenys. So just to say thank you very much for that. I mean, I think this is we've been on this journey with this particular business case. I mean, I think it has immeasurable benefits, and I can see no negativity. And I think the issue that Shelley's just raised has been answered. I think we've got the COVID recovery and all the sort of things linked into that and the additional capacity. So I'm again on this particular scheme, which I think will make a very big difference to the community. And I've also noted there's been very sound engagement with local stakeholder groups, patient groups, and also with the CHC. So the message, the music coming through is go ahead with this. And again, I would give this my total support. Thank you.
Pippa?
Yes, I mean, I can only echo the fact that I think it's a really great project. I have one question and one which is really just around clarity for me, because our investment objective is to increase the number of day cases from 30 to 70. So that's the objective. But actually, we anticipate the benefits increasing to 80%, not 70%. So is that we are certain that we're going to get 70%, but actually we could get 80 or 85% or something like that. So it's just clarity for me really around that, because plainly the benefits are massive, aren't they? It's a huge leap. The other thing is the October date. I'm assuming that you're quite confident that you can be breaking ground, I think is the expression, isn't it, in October. And October to me feels quite close. And what do we do if there are any delays caused by the money being delayed coming into us? I think, I hope that makes sense.
Okay, do you want me to, Andrew, pick up the first one around the day case?
Yes,
yes, please.
Yeah. Day case activity I think there's scope to do a lot more, because we're even seeing in some places where they're doing simple mastectomies as day cases, which we're not. So we've got a big programme of work, not just around breast, but around our overall day case activity and how we're going to improve that to become much better than we are. With the breast unit coming on, Neville Hall, their day case rate's been poor because of their wanting to access beds. So patients have which could have been day cases, have come in the night before to ensure they get to theatre. So immediately those bed day savings and day case activity will come to the fore early on. And I think there's a lot more work to do around some of the other pathways, improving them, streamlining. So I think we'll get to 80% plus. The numbers that were put in that need to go to off-site, again, I think as we get up and running, we'll see that less and less patients do need to go to the Gwent for their surgery. It's getting that confidence level, isn't it? And the right patient selection. And linked to that, there's a big piece we're doing around pre-assessment too, so that we can make sure that we get the patients that are day cases treated as day cases.
That's really helpful. Thank you. It absolutely clears up my question. Thank you.
Thank you. Tish and then Helen.
Can I address the second question? Sorry.
Oh, sorry.
Yeah. So on the issue of construction starts, we're basically in the of Welsh Government. So I've allowed 2 months from today, because after this meeting, if the business case is approved, the information will be sent directly to Welsh Government. I've allowed 2 months, as I say, which should be enough for them to approve it, but it is in their hands. So obviously we can't sign a contract with the company until we get full Welsh Government approval. So, and they will take about 2 to 3 weeks to mobilise their teams. So it should be October, but it may be November, which isn't ideal. Obviously starting at the beginning of winter, but it should not be any later than that.
Thank you.
Thank you. Tish?
Thank you, Chair. Like others, I think this is an excellent piece of work, and it's fantastic to see it moving forward. And we have seen this several times, and the development. Just one thing that I'd like to pick up on. I was really pleased to see that we have done an assessment around patient travel times and costs. Because quite apart from that being consistent with our socioeconomic duty, we as a board have always been concerned about that, as I'm sure patients are and will be. It would just be really good when we first engage with patients, when they first have a diagnosis, that this is explained to them, that they will need to make fewer trips, and therefore the travelling and the cost is offset. So where they might have had to go to many facilities in the past, now it's a one-stop shop, and so it might feel like a long way away, but they'll get the best care and they'll get it in one place, so there will be fewer trips and less disruption. So as I say, I'm pleased that we have paid due attention to our socioeconomic duty, but also that this is consistent with our striving to meet green health principles, because again, we are reducing the number of travel incidences for our patients.
Thank you, Tish. Very important points made there. Helen?
Thank you, Chair. Just obviously to reinforce what other people have said, and having from experience, having a one-stop centre and a purpose-built building will definitely improve the efficiency of the service. And I think, one of the key problems that breast services face at the moment is the shortage of radiology input. And anything that you can do to amalgamate your teams, and you will improve the efficiency of how you deliver the service during the week. I think the other thing that people mentioned about day cases, I think interesting, one of the impacts of COVID has been that many more patients are much more willing to be treated as day cases than they were before, whereas the standard was, we'll stay overnight. I think, COVID and streamlining the service has meant that many more cases can now be done as day cases, and that's changed the philosophy of how people look at things. So I would support the case, and obviously the sooner the building can start, the better, really, so that you can improve the services across Gwent.
Thank you, Helen. Are there any further comments or questions? If not, I take it that we're all agreed that this business case is approved.
Yes.
And sent out, and I think it would be good practice to ensure that that we do keep a very careful track on the improvements that we wish to see from this development over the performance of the service in the future. I think it'd be helpful to do that. Thank you. Okay. A single public service board for Gwent. Richard.
Thank you, Chair. Yes, this is a request to look at a single public service board for Gwent. The paper explains that at the moment that we have 5 currently under the Wellbeing and Future Generations Act, and there's been discussion on a Gwent-wide basis for a merger of the 5 to create one on the footprint of the health board. I think those recommendations and the explanation within it seem reasonable in terms of how we provide our services and what we need to do. And then the paper provides the terms of reference and the people, organisations involved. So essentially, it's asking, do you approve for the health board to participate as one PSB in one PSB organisation?
Thank you. Are there any questions? We have discussed this before. Are we content to agree that we wish to participate in one board? Good, thank you.
Thank you.
I think we just need to, on the paper that we have, we just need to clarify that when it suggests that there'll be one representative from Public Health Wales, we have clarified this with the leaders that this will be our Director of Public Health, and that has been accepted. So I think that we just need to be clear about that. Okay, thank you. So we're happy to endorse that. They are aiming to have their first meeting, if everybody agreed, in September. So we'll be able to report back on that further to you. Thank you. The review of the delegation of revenue budgets, Glyn.
Okay, thank you, Chair. This has come for decision to the board, and it follows on from the meeting that we had in March, where the board agreed to delegate budgets at the start of the year. That's what we normally do. But I think particularly given the level of uncertainty that we're facing this year around COVID and the consequences of COVID, the board sensibly agreed that we should review the level of revenue funding that we have available and how we delegate budgets on a quarterly basis. So particularly we've got uncertainty around the level of revenue funding that we know that we're likely to get during the course of the year. I think it's also fair to say that given some of the service pressures that we're seeing, being clear about what our service and workforce requirements are during the course of the whole year and what the cost of delivering those, again, is unclear at the moment. And then the third area is around the level of savings that we think we can realistically deliver during the year. So those 3 particular factors meant that actually it was probably sensible to review what things were looking like on a quarterly basis. So we agreed to review the budget position, bring a paper back to the July board based on hopefully having greater certainty at this time of the year. So I wanted to just sort of cover off those three broad areas in considering how we delegate further funding to our delegated divisions and directorates. So in terms of revenue funding, I think since March, it's probably fair to say that we've got greater certainty around COVID funding for quarters 1 and quarter 2. In some areas where we've got nationally funded programs, so things like the contact tracing service, we've now been given funding certainty for the rest of the financial year. What we don't have at the moment is a clear understanding of what the level of COVID funding will be for quarters 3 and 4, so the second half of the year, and therefore we are still running with a level of financial risk and uncertainty. If we then move on to service and workforce assumptions, again, I think we've probably got greater clarity now than we had back in March. The Health Board has submitted its annual plan, and that's on the agenda later on in the board. That was submitted at the end of June. But I think probably even since then, what we've seen in terms of current service pressures is probably quite different to what we perhaps anticipated at the beginning of the year. So as we move through the third wave of the pandemic, whilst our COVID admissions are probably creeping up in terms of hospital admissions, the level of demand for non-COVID services, particularly urgent and emergency care across the health, is quite significant. And again, we'll cover that in more detail in one of the other board papers. But that in itself is then driving our requirement for increased workforce, which in turn then drives a need for a different level of financial resourcing as well. Our workforce, we know, is impacted by things like self-isolation rules, higher than normal levels of sickness. And I think it's important to understand that our workforce is also recovering from the challenges of the last year during the pandemic, and at the same time taking annual leave that they weren't able to take during last year. So when you look at your workforce requirements, that all adds up to needing a higher level of workforce to be able to deliver and respond to all of those service demands. So the financial plans that we've built around that try and make the best possible assumptions as we go through the rest of the year. But what that inevitably means is we will probably rely more than usual on things like increased use of agency staff, locum staff, and we'll talk a little bit about some of the things that we're doing to try and convert some of that to greater use of substantive staff. But again, what it's doing is driving additional costs over and above what we would normally be operating as a health board. The third area then is around savings. And again, I think it's important to recognise that the health board has focused much of its attention on actually responding to the demand that we're facing in terms of COVID pressures, but also I think we're seeing the consequences of the last year of pandemic and the fact that people are now beginning to access emergency and urgent care services again. We're also looking at trying to recover some of our access times and therefore understandably some of the progress on savings isn't at the level that we would normally want it to be. That will impact on the health board's ability to make further investments recurrently. But when you put all of that together, it means that we've got a more challenging financial position this year. So the paper sets out the level of funding that we think is probably realistic that we can delegate at this stage. You will see from our reserve position that we're holding what would appear to be quite a significant reserve. And this is in part because we're unclear about the level of COVID funding that we're going to receive from Welsh Government, particularly during the second half of the year. So there is around about £54 million of COVID funding in our reserves that we've yet to have confirmation around. So again, it's important to note that that does represent a financial risk to us. We're currently waiting to hear formally from Welsh Government on our annual plan, which we would expect to also receive confirmation around funding allocation. So whilst we hope that we will hear something in the next few weeks, at this point in time, we aren't clear about what the funding position looks like for the remainder of the year. So in summary, we're asking the board to approve a further delegation of funding at this stage, acknowledging those financial risks that I've outlined, acknowledging that they still exist. And what I would advise the board on is that we do a further review of our revenue budgets, particularly those three areas that I've talked about, and we bring that back to the board at its meeting in September. So effectively we can present a Q3 budget position for the board to approve. That's all I really wanted to cover at this stage, Chair, but happy to take questions before we ask the board to approve the delegated budget position. Thank you.
And you'll have to excuse me, we've got the builders coming in and there's a nurse coming to see my wife.
Okay. Thank you, Keith. Thank you. Hope it's all right. Thank you.
Okay, bye now.
Bye-bye. Paul?
The paper is incredibly detailed and I think actually is eminently sensible with regards to what's been looked at. It seems to me what we've been asked to do is to look at a quarterly review, which makes sense because there's some uncertainties with regards to the confirmation of allocations, and of course with the COVID situation that's ongoing in terms of the funding that's likely to be coming our way, hopefully. But ultimately, the key point that I felt was important was within this report was the aim is to support financial balance. And I think it is important for us as board members to be aware of our responsibilities in terms of our overall budget. So having looked at what's being proposed, I think is eminently sensible. I would support entirely what's proposed, and to thank Glyn and the team really for, I think, for doing a great job in putting all this together, because it's an incredibly important area of activity from our point of view. So I think that I would support the recommendations because I feel they are realistic and also helpful, and we need a period of time to await further information, and therefore the quarterly approach makes a lot of sense. Thank you.
Thank you, Paul.
Thank you. Shelley?
Yeah, actually, Paul said everything I would have said. So, and obviously I've discussed this at length with Glyn, and I do think it's the right approach. And I also agree that, Glyn mentioned a further review for Q3, and I think that's going to be essential. We'll know more about where we are and what the likelihood is in terms of our outturn by that stage as well. So yes, I would endorse the report.
Thank you, Shelley.
Thanks, Shelley.
Are there any further comments and questions? I think it is absolutely essential that our primary aim is to maintain this financial balance whilst ensuring that we can deliver the care that is required by the population in very uncertain times. And obviously there are other areas that probably will pop up during the year that will require us to consider how we fund them, because we don't yet know, A, what's going to happen, and B, whether or not the pressures in the system are going to be funded, although I'm sure that the Welsh Government will do its absolute utmost to ensure that we are covered in these very uncertain times. So are we content to endorse this report and the delegation of the budgets? And thank you very much, Glyn, and your team for a very comprehensive report, which clearly has outlined the thought that's gone into how we can manage this, and your success and your teams in acquiring the resources in the first place, and for maintaining the confidence of the government in the way in which we address our financial issues. So thank you very much. So that is endorsed. Thank you. We move now to the Welsh Health Specialist Services Committee standing orders for approval. Remember, this is a joint committee responsible to health boards for the commissioning and securing of specialist services within Wales for our populations. So, Richard.
Yes, thank you, Chair. As the Chair says, this is a part of our governance framework, and within the information pack that you've been provided, you will have been provided with the standing orders, copy of the standing orders, and a letter explaining what's required in terms of the review, what's happened, and about the WISC governance and accountability framework. As part of that process, we are required to approve the standing orders to form part of our standing orders, and this paper is just there simply to actually ask for that recommendation to go forward and include it as part of our own governance framework as part of the Health Board. And if there are any questions.
Thank you. Thank you, Richard. Are there any questions about this? No. Are we happy to endorse them? I think I have to advise you that I have asked for a further clarification. I've spoken to the chair of WISC on how we will operate the accountability framework, because that isn't detailed. at any length in the standing orders, and that can be dealt with outside the agreement to the standing orders. So thank you for that. And
I will take that. Sorry, Chair. I'll take that to the board secretaries as well.
Thank you. That'll be very helpful. And similarly with EASC.
Yeah. So similarly, this is the Emergency Ambulance Services Committee, and similarly again, this there's a requirement to endorse these standing orders to form part of our governance framework, and obviously that's a similar process for WISC as well.
Thank you. Are we similarly happy with those to adopt them? Thank you very much. And then the final annual plan 2021, we've had a number of presentations on this over the past couple of months, and this is the final document. So Chris, please.
Yeah, thank you, Anne. And so we've got this document here today for formal approval. We've submitted it in draft to Welsh Government, and we're asking you today to formally endorse it. It's a piece of work I'm incredibly proud of, and particularly because I think it demonstrates the ability of the organisation to think long-term and think population whilst in the middle of a pandemic. Yeah. We produced this document in January and February this year, which was a really, really challenging time for the organisation, and actually for staff and for a number of departments to be able to also consider the long-term approach of the organisation is something I'm incredibly proud of. So as you know from the presentations that we've taken to the committees and to the board previously, we've adopted a life course approach and that overarching focus on health inequality as a primary driver for the organisation. And we're already seeing that shape our decision making and help us as we move through this next phase of both pandemic response and long-term thinking. So when we've been looking at recovery, and looking at in terms of proposals that we've put to Welsh Government, we've very much tried to focus on our annual plan as the driver. So that focus around tackling health inequality, that focus on whole system, and that focus on sustainable transformation, not simply looking at actually how do we reduce backlog waiting lists, but how do we ensure that we get consistency of delivery across, in particularly primary and community services. So we're building a stable base for the future, not simply focusing on immediate planned care recovery. The plan has so far had really positive support from Welsh Government. We are waiting for the formal sign-off and feedback from Welsh Government, but I know from the joint executive team meeting it was really well received by Welsh Government, and they were particularly in favour and pleased with the way that we've taken the life course approach to the plan and our ability to really align with Healthier Wales and the policy direction of Welsh Government. And I also think the plan really well aligns with the National Clinical Plan, which was published recently by Welsh Government, which again promotes a pathway and life course approach to working. So just by way of a couple of developments that we've taken forward in Q1 and some of the work we've done around the plan. So it's in the paper, but just to note that we have updated our demand and capacity and the sort of underlying work under the plan in terms of our bed modelling and our planning for the next few months. And Glyn kind of alluded to this as part of the financial plan. One of the real things that we've set out in the plan, and I've talked to the committee, and particularly the Strategy Planning and Partnership and Wellbeing Committee, about our approach to dynamic planning and using live data. So we have been able to update through Q1, and in terms of understanding our urgent care pressures, looking at the activity we've been able to do in terms of our performance in terms of planned care, but also taking on board revised guidance from Welsh Government. So when we originally did the minimum data set work in the plan, we had only taken into account operating in a COVID environment for the first 6 months of the year. We have now extended that to the full 12 months of the year under the guidance from Welsh Government. So we can expect to be operating in that COVID safe environment right through for the remainder of the financial year. Importantly, as part of that process of planning and refreshing the plan through Q1 and the sort of underlying minimum data set work, which is where we bring together the operational plan, the workforce plan and the financial plan, it's about making sure that we get that balance across those areas. We know, and I'm sure we've talked about this many times as a board, that the risk in the plan is around our ability to the workforce to meet our ambition in terms of recovery and in terms of delivery. But actually, we've got a lot of good work that's gone on in terms of recruitment, in terms of looking at alternative roles in order to meet the challenge of that. And our planning is based, and the demand and capacity planning is based on that sort of what if nothing changes scenario. So if our urgent care pressures sustain as they are, and there's elements, and we'll come on in a later paper to talk about many of the range of activity that we're doing to try and change that that situation. It's also worth mentioning that through this first quarter, in the plan, we set out some of our ambitions around recovery, and we're already making good inroads in restoring services in Q1, and that's through taking a risk-based approach to recovery. So we've done a tremendous amount of work in terms of categorising patients on waiting lists by their risk category against the Royal College of Royal College of Surgeons risk-based categories, and we're making really good progress, particularly in those most urgent patients, in terms of reducing both that 52 and 36-week waiters, and we'll come on later to some of that information in terms of the performance report. And we've also restarted a significant range of services, both in our acute sector, but also importantly in primary care, and getting that balance. I just wanted to mention as well then, and I know Glyn mentioned this as well, that there was an initial tranche of 100 million available from Welsh Government support recovery, and we were so far being successful in securing 17 million of funding to support some of our recovery. But importantly, linking that back to the annual plan, and that we've been trying to focus on building a sustainable base for the future, as well as some short-term activity in terms of reducing waiting lists. And then finally, as mentioned in the paper, we've been making sure we've got the infrastructure for delivery. So establishing our programme approach for delivery of our important change programmes as an organisation. So we have now recruited a new Assistant Director for Transformation who'll be starting in September, and building a programme team to give that extra support for teams as we develop important programmes. And we've established now a group, a sort of overarching programme board for the organisation, which is really driving work. And we've prioritised urgent care work specifically around that. And I know we've got a paper later on that on the agenda. And we had really good approaches looking at the last meeting in terms of deep dive work on outpatients and musculoskeletal conditions pathways. So we're really able to make good progress now in implementing the priority areas for the health board. I just want to finish in terms of introducing the paper with some big thank yous. So I started by saying how proud I was of the organisation in terms of looking at a life course approach in the middle of a pandemic. So thank you particular to teams for their work across the organisation. And a final thank you particular to Ethna Hunter and Jen Kate in the planning team, who are the ones who actually coordinated the plan and turned my thinking into actually what I think is a really good and robust document that sets out our ambition for the future. So that's all I wanted to say. Thank you.
Thank you very much, Chris. And it is indeed a really succinct and helpful report, which we'll be able to track very well indeed to see that we are achieving the objectives within it. And it's helpful to note that Welsh Government has endorsed our life course approach, which is useful, very useful. Paul?
Yeah, I was just going to echo that really, and to say I think it's a great report, bearing in mind this is a different approach. It's an annual plan as opposed to the integrated sort of model that we used to have. So this is the first sort of attempt at this. I think there's an outstanding report as such. And I think that the fact that it's been well received by Welsh Government, I think says a lot. I do support and endorse this sort of pathway life course approach, because I think it makes a big difference with regards to the sort of what's contained within the report. Also, I think we've taken into account the sort of Wellbeing and Future Generations Act principles as well, which I think again is important. And perhaps the final point I wanted to make about this particular approach we've adopted is it's important we've got one plan which we can sort of link into all the other plans rather than these isolated plans. So in fact, this particular plan fits in very well with the Healthier Wales, and I think the clinical model was mentioned earlier. And I think the more we can do that, the more helpful it becomes, because there's one plan that staff then understand, as opposed to a proliferation of plans that everybody knows that are there, but not quite sure which plan it is. So one plan approach makes a lot of sense, and I think it's a great job, well done under very difficult circumstances. And I think that this is congratulations to all involved in putting together this very comprehensive, thoughtful, and I think it actually reads very well, and it's in terms of it's got a good balance of information contained in various formats. So well done to all involved.
Now we've just got to deliver it.
Absolutely. That was the last thing I was going to say. Now it's important to say, right, we now need to see some actions. Thank you.
Thank you. Tish?
Thank you, Chair. I did have a question. I think, Chris, you've answered it actually, but if I can just offer a reflection. I think excellent, and as several people have said, we have seen iterations of this, and we've seen the development, which is excellent. And that does give us the opportunity right at the end to sort of take a step back and look again with fresh eyes at how this annual plan in a very difficult year looks from fresh, and that's what I did, and I did question whether we might fit, because I very much endorse the alignment between the plan and the principles of building healthier Gwent and population health and that approach. I very much endorse that, but I did wonder whether that would feel a little out of touch when we have so much acute pressure on the system for an annual plan. However, I think you're absolutely right in stressing that what we are doing here is addressing health inequalities, and that we are taking a whole system approach, because if we don't do that, then frankly, we're going to end up, running around trying to stick patches on things. And I think it's a brave plan, and I think it's the right thing to do, having done all of the engagement and research. So I would commend this plan. I'm really very pleased that it's been approved.
Thank you, Tish. Shelley and then Emrys.
Yeah, Chris and the team, I would absolutely endorse. I think it's great, and I think it is a good read. And so the one thing I wanted to just ask you was in relation, it's the point that Paul raised, which in a way we've got one plan. We might have lots of other plans, but we've got one plan everyone can focus on. This is our ultimate goal. I just wondered how that was going to be communicated down to maybe things like primary care and our NCN groups, because I think it's so important that they understand what the priorities for the health board are and how they support the work of the health board and vice versa. And I think perhaps in the past the IMTP has been quite a bit unwieldy, and perhaps people haven't really necessarily got to grips with it, whereas this is such a good, succinct document. I just wondered, Chris, if you knew if there were any plans to make sure that people understand how it all fits together.
Yeah, do you want me to answer that one now, Anne?
Please, thank you.
Yeah, so a really important point, and it's important that it's not a document that sits on a shelf and grows dusty, but actually helps the organisation in its planning and prioritising. So I've been essentially going out on tour a bit in terms of going out and talking to people and having a simple presentation that we take out to various teams. We've also done some wider engagement sessions around the plan within the organisation. And then we are trying to further, and I was speaking to Karen and the comms team about this just last week, in terms of developing some short videos and some information that we can put out to teams about the annual plan and about their role and how their work fits into it. So we are going out and doing that work in terms of that engagement.
Oh,
thank you, that's lovely, brilliant.
Emrys.
Thank you. Excuse me. Thank you, Chair. I've just got a comment and one question, really. One is obviously echo colleagues' comments in relation to what an excellent plan that we've got in front of us as a health board, and I'm just pick some of the key points there. And we've included things like recovery. It's a risk-based approach, and we focus on patients' needs, and in the true spirit of integrated governance. We've also looked at finance, quality and activity that's linked here. My question is that when I look at the delivery framework, and I suppose it does link to what the last two comments that have been made, is that Welsh Government is telling us to look at our service models from a systems perspective, and we're looking at it from inpatient to community care. But there is also, we're reliant on other colleagues to be able to deliver other aspects of care in the system. Otherwise, our system was not going to deliver as expected. So, for example, and I noticed you made the link to the RPB here, is that whilst we put a delivery plan against this, there will be some reliance, for example, on the local authority to do their part in on social care. And I would assume that they're going to have to marry up some form of social care plan in respect to the needs there to make sure our system's effective.
Yeah, I think that's a really good question, Emrys, and one of the first places that I took the plan in terms of discussion was to the RPB in terms of discussing our approach to it and recognising, and I think we've tried to highlight that within the plan, about it is a partnership first approach, and that we won't achieve the ambition of the plan without those partners alongside us. So making sure that we are connecting and linking in those plans. And I think it relates to the earlier item in terms of one public service board, and the more that we are able to align our plans and our ambitions and sort of the outcome measures that we build around it across the one PSB, across the one RPB and the plan, we will gradually bring together that alignment and then the accountability that follows as a result of that.
Thank you. Sarah, did you want to add to that?
I was going to say the same thing. Thank you, Chair. I think the only bit I would add is that, as I've put in the next report around a healthier Gwent, the RPB is in the process of updating its area plan for March next year. All public service boards need to align with government elections, and therefore there needs to be a new PSB wellbeing plan by May next year. So therefore the opportunity to align those plans, and we can discuss in the next item whether it's too ambitious to consider a single plan or not, but certainly moving in the direction of alignment, it's an opportunity not to be missed.
Absolutely. Yeah, thank you, Sarah. Are there any further observations or comments? If not, I think we thoroughly endorse the annual plan and look forward to receiving the updates on its achievement. And I think we're very, very pleased that obviously it has endorsement from the teams that have to deliver it on the ground, which is vitally important for success. And we look forward in the planning committee to receiving an update before the next board meeting. Thank you, Chris, and your team for a really good piece of work. Thank you. If we go on to items for assurance, Cancer Services Annual Report, then please, Sarah.
Thank you, Chair. I think the intention is that we play the patient story at this point as it relates to this report.
Okay.
Yeah.
Chair, if I may, I'll just introduce the story.
That'll be grand, Rhiannon. Thank you.
Thank you. So this is Gail's story, and Gail was a nurse that used to work in Aneurin Bevan University Health Board, subsequently retired. And the story has been prepared to support the presentation of the cancer annual plan, as Sarah's just outlined. But I think board members will recognise it's also closely aligned to our previous item regarding the business case for the Unified Breast Centre at YYF. Gail was diagnosed with breast cancer, and through the story she shares her experience of receiving the diagnosis and her ongoing care during the pandemic and the impact this has had for her and her family. In the foreword of the annual report, we say that cancer touches the lives of everyone, and I think Gail's story is a very powerful and impactful reminder of this. And she shows us the importance of emotional and psychological care, as well as physical care and treatment. I'm incredibly grateful to Gail for sharing her story, which has been quite difficult for her and emotional, but additionally to Tanya Strange for facilitating its production. So here we go to listen to the story ahead of the presentation of the annual report. Thanks.
Thank you, Rhiannon.
Hi, Chair. I'll put it up now. Please can you tell me if you can actually see it?
Okay.
Is that okay?
No.
Can't see it?
Not yet.
We can see the screen, so if you press play, we will be able to see it. Thank you.
Okay, thank you.
Yeah.
Hello, I'm Gail. I'm a retired nurse, wife, mother, stepmother, sister and grandmother to our family. I saw myself as someone who everyone looked up to for help, care and attention. However, last year was challenging for everybody due to COVID, but for me personally, it was extremely traumatic as I found a problem with my breast in the middle of a pandemic last July. I was seen that day by my GP, and within days I'd had my first mammogram. I was told I'd have the results within a week. However, days later I was recalled back to the Royal Gwent Hospital. My husband came with me for support, but he was denied access due to COVID. Therefore, he had to sit alone in our car for 3 hours, waiting for me whilst I was having further tests and investigations performed, alone and afraid, in outpatients. Firstly, an ultrasound scan was performed, where I got to see my mass for the first time on screen. No one said the word cancer, but I knew instinctively it was cancer. There, the professionals decided to take 3 punch biopsies and attach a clip to my mass. I was stunned, frightened and extremely vulnerable. 3 hours later, I left outpatients and broke down crying to my husband. At this point, I hadn't told anyone in the family about my cancer because we were all alone at home, isolated, and I felt I had to protect them. However, the test results showed it was cancer, and telling my family was heartbreaking for us all. At that point, I knew I had to be strong for them all, as they were all falling apart, including my husband. A date was set for my first operation, and I was asked to choose a mastectomy or a lumpectomy. Going into hospital in a pandemic was very frightening. I felt scared and out of control. How could my body be decaying inside without me knowing? My first op went ahead. However, I was later informed that they needed to remove more breast tissue. Plus, it had spread to my lymph nodes. At this point, my anxiety levels hit the roof, knowing that my cancer was still inside me and spreading. During the isolated long wait for my second operation, my sleep pattern became so poor and my anxiety increased to the point where I was prescribed antihypertensive medication. I saw my GP and asked for a CT scan to see if my cancer had spread any further than my lymph nodes. Going into hospital on the first occasion was bad enough, but going in the second time, plus needing an overnight stay due to my lymph node clearance and requiring a drainage bag, was horrendous. Following my surgery, I was passed on to Velindre Hospital, and they chased up my CT results, which then evidenced that I have further medical problems and they will be ongoing over a yearly period of time. So they arranged an MRI scan. Still, we were all isolating. Days before Christmas, I commenced my radiotherapy, and in one session, I finally broke down crying. Staff at Velindre suggested that I visit Maggie's next door. However, when I went to visit, the door was closed on me, and I was told to go and look online because they were shut due to COVID. Unable to do this, I continued to feel lost, lonely and afraid, as did my family, who were still unable to visit me. A New Year's Day came and I cried all day and the following day. And eventually, mid-January, I was contacted by a clinical psychologist who suggested that I wait for my MRI scan and the results so that we could commence counselling. I cried throughout our conversation. Weeks later, my MRI results highlighted further medical problems for which the monitoring is now ongoing yearly. So I pulled myself together and I told the clinical psychologist I was okay. I realise that we are living under exceptional circumstances. However, it's now 12 months since I discovered my breast cancer. So on reflection, I feel the impact of the cancer diagnosis and treatment is awful at any given time, but throughout a pandemic where patients are left isolated and alone, makes them more afraid and vulnerable. I have come to appreciate that my physical needs were addressed in haste. However, my mental health needs were left undetected far too long, and I feel that highlighting my story will improve the patient's journey. I will always be eternally grateful to our wonderful NHS for saving my life.
Hopefully the video is finished now, and we're back on.
Thank you. And can I, on behalf of the board, thank Gail so very much for sharing her deeply upsetting and grueling experience with us, so that it will enable us to improve the way in which we deliver more holistic care to individuals more satisfactorily in the future. I think it was extremely brave of her after so little time to be able to do that. So thank you so much. Sarah or Rhiannon?
Well, thank you. If any, I don't know whether anybody wants to say anything more after the film, or should I just carry on to the report, and perhaps if we pick up on the film as I go through.
Yeah.
Yeah, thank you. So I'd like to start by giving apologies from Dr. Ian Williamson, who is the Assistant Medical Director for Cancer Services and Vice Chair of the Cancer Board, who has been a tower of strength over the last year and intended to be here today, but has needed to visit his family this week. The report that you've received sets out progress over the last 12 months towards the cancer strategy that the board approved in November 2019, and it's a succinct report, so I won't dwell on it too, in terms of the detail too much, because everyone will have read it for themselves. But I thought there were some important points to pull out. The first, really, on page 7 is a diagram of the rapid changes that were made to our service delivery in response to the pandemic to enable timely diagnosis and treatment to continue with a lot of adaptation. And I mean, while Gail's film clearly tells us we need to do a lot more about what matters to patients, the focus on timely diagnosis and treatment that has been the focus of the Cancer Board, at least it was good to hear that at least that bit went well. So the page 9 of the report describes the disruption to screening programmes, which stopped completely for 3 months in the first wave, which is a concern because the whole point of screening programmes is to find cancers early to improve the outcomes of treatment. And the Health Board is working closely with Public Health Wales to help as best we can with recovering the screening programmes and also to deliver our part of the pathway for those who have a positive screening test. Page 10 describes the reduction in GP referrals that we have seen, and the Cancer Board asked the question very early on about whether that was patients not attending their GP or GPs not referring, and we've kept that in mind. And all of the data suggests that when patients present, GPs are referring, and I think that you see that in the conversion rate. So our conclusion was that patients were fearful of presenting, and from very early on, we put out a lot of public messages encouraging people to attend and encouraging them to attend their GP, because if they were worried about cancer, because we were still open and everything was still working. And we are seeing those referral rates recover, but there was definitely a dip. And but we also set up the vague symptoms clinic, which we'd been wanting to do to make it easy for people who didn't have definite symptoms of a particular cancer. And we are now introducing See the Signs in Primary Care, which is a prompt to the clinician to think about cancer if patients are describing. As a whole has held up remarkably well, and there's an enormous amount of clinical effort that's gone into managing to achieve that through all the disruption to services. There has been some variation. Of particular note, early on the decision was made. Value-based healthcare had done a small pilot of asking patients being referred with symptoms of bowel cancer to do the same screening test as the bowel screening program uses, to identify those who were most likely to have bowel cancer. And that has been introduced for all patients, with the effect that with the reduction in colonoscopy capacity, we've been able to use it for those most likely to have bowel cancer. And that was a rapid innovation that has undoubtedly helped to keep diagnosis going. And then on page 13, there's a summary of where we are against the more strategic elements of our cancer strategy, and all of which have actually progressed over the last 12 months. And then page 14 talks about the services we're providing for people living with cancer, but in the light of Gail's story. Providing diagnosis and treatment, but that his words were, we've lost some of our humanity. And I think Gail's story just describes that. And we need to regain our humanity. The page 15 has set out the assessment of our strategy against the new national quality attributes for cancer, which you can see actually aligns pretty well. But again, what matters to patients is one of the gaps that we actually need to give more focus to. And so the summary is that our clinicians have actually shown remarkable resilience in maintaining diagnosis and treatment, timely diagnosis and treatment through very difficult circumstances. But going forward, we need to give much greater emphasis to what matters to patients and the patient experience. And so the board is asked to note the report for assurance.
Thank you very much, Sarah. And thank you for the succinctness of the report, which is really very, very helpful. And I think we'd all endorsed your comments about concentrating a little more on matters to patients and helping them through this very difficult situation in a good way for them. Are there any questions or queries to Sarah? If not, we look forward to. Oh, Emrys, sorry.
So it's not a question, Chair. It's just a comment, and it's just adding on to what Sarah's saying as well. Is that that was an incredibly powerful message that we had from Gail today in that presentation. And you know, often we talk about process and the requirements around process. And again, you know, in the true spirit of integrated governance, we've got to think about emotional well-being as well in respect to this. And that notes to, I recognise that from all colleagues' comments here today. Because if you think about it, I was just reflecting on what she shared with us, what Gail shared with us. I should also mention as well, a special mention to Tanya Strange as well, in helping to pull that film together. As I think that's what who Rhiannon said at the beginning there, because that hits to help get the message over as well. I thought that was very, 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 very clever. But from our perspective and listening to that, there's something about Gail as an individual. There's something about Gail's family, you know, there's something about the communication that we need to think about in respect of this. You know, we quite really talk about the diagnosis and the action, and also what she shared with us about where she was waiting for psychological counselling as well, because we had to wait for a result first. So I think recognising colleagues, some of the comments made already, there's two things I think that we need to be thinking about, and I'm sure they are anyway. Is one about what do we do in response to that, to the emotional well-being, how that becomes almost like a standard method of working going forward. And whatever we do then is about how we communicate that back to Gail on, you know, she's been brave enough to share with us her experience. And then we've also got to be brave enough to share back with her as to what it is that we need to do in what we are doing, which I'm sure we are in respect of what she's shared with us.
Thank you, Emrys. We totally endorse that. I think that's really important. Thank you. Are there any further comments or questions? Thank you very much to you and Ian for producing this report, Sarah, and to Rhiannon and Tanya Strange, and particularly Gail, for sharing her experiences with us. It allows us to step forward on improving our services for people. Very well indeed. Thank you. Could we move to a healthier Gwent, Sarah, please?
Thank you, Chair. So the accompanying SBAR report sets out where we are with taking forward a healthier Gwent in some detail. So I'll just pull out the sort of key points for the board today, which are that the scale of the disruption that has been caused by the pandemic creates an opportunity for a step change, and in the words of Sir Michael Marmot, to build back fairer, in order to recognise that the pandemic has widened health inequalities, that those who were already most disadvantaged with the most serious health conditions are actually those who've been hit hardest, and therefore a renewed public sector effort in Gwent to build back fairer, to reduce health inequalities. And as we've already said when talking about the annual plan, the alignment of the development of a wellbeing plan, whether it be 5 PSBs or 1 PSB, there needs to be a new PSB wellbeing plan by May next year, a year after the election. The area plan that the Regional Partnership Board needs to produce by March next year, and then our own annual plan, which is already aligned closely to the current PSB plans. So it does feel like a unique opportunity over the next 12 months to make progress on that ambition in a healthier Wales, to see increasing alignment between Health Board, PSB, RPB and national planning. And you'll see in the paper that I've very explicitly aligned it to the Building a Healthier Wales strategic coordinating group, which for Welsh Government is the national coordination mechanism for the prevention part of the agenda. So I just think it's an opportunity. I don't know. I think I'm proposing we should be ambitious, and we may end up not getting all the way, but I think we should try and make as much progress as we can over on the back of that opportunity. What I'll describe as the triangle diagram, it needs to be sort of something that we can all describe if we're going to provide system leadership, because the core principle, the reason why it's the shape it is that the foundation for health and well-being are the wider determinants of health. A good educational attainment, good work, secure housing, secure finances. Those are the things that determine people's mental well-being, and it's that people's mental well-being that underpins their lifestyle behaviours, which is what then leads to clinical risk factors and ultimately illness. And we have historically tended to start fairly close to the top of the triangle with somebody's got high blood pressure, or maybe that they're smoking, but people are not going to give up smoking if they're very worried about security of their finances, their home, their job, and therefore their mental well-being is poor. We need to start where they are and work from there. So I think that concept for the NHS is one that we need to, as a board, I think, embrace and provide leadership to help connect all the parts of the public sector. And you'll see in the report actually quite a pleasingly large range of programmes of work that are actually happening despite the fact that we are still responding to the pandemic. And it certainly gave me heart writing it that we are actually doing quite a lot. And so the recommendation is the board are asked to note the progress that is already being made, but in particular, and I asked this when I presented my annual report 2 years ago, it is to ask the board to provide that system leadership to realise the opportunities that I think we have over the next 12 months that, if we miss them, probably won't come our way again soon.
Thank you very much, Sarah, and thank you for such a succinct and helpful report. This is really a vitally important piece of work and a key priority from the new minister, who is really, really keen to see how we can progress this agenda over the next 4 or 5 years. It's really, really important, and we will be tested on it. And I think we've made a very good start, but there's a lot of really hard work here, and changing hearts and minds is going to be important. So thank you very much for your leadership of this, Sarah. Paul?
Yeah, can I just endorse what you said, Anne, and also just to say to Sarah that I would agree entirely with what's been said. I think the more ambitious we can be to try and deliver on what is proposed, that's incredibly important. At the moment with the pandemic, etc., it's been incredibly difficult times, and I think we need to look at opportunities. And I think once in a lifetime opportunities to be able to do things, and I also would agree in terms of the work that has currently been undertaken, which I think is excellent as well. So I think we should really go for this and do as much as we possibly can in partnership with others to make a real difference. And so I would hugely supportive of what's proposed.
Thank you, Paul. Are there any further comments? Emrys?
Yeah, just a quick one, Chair, to Sarah. You've asked us to note the triangle or the pyramid of actions there. Is that, and I'm not expecting a comprehensive answer on this now, but I'm just thinking going forward, I suppose it would be helpful if we can correlate the links between, wider determinants and some other aspects within the triangle to show how we're progressing going forward.
Thank you, Emrys. So pre-pandemic, a colleague in Public Health Wales was leading work on developing logic diagrams for the impact of the wider determinants of health on outcomes. And so I think there was quite a lot of work done that we can now, bring back to life. We'd got as far as developing the logic diagram. We hadn't actually got to the point of using it in practice. So I think that, and then the comments from independent members in previous discussions around how do we measure progress, and you'll see that one of the next steps, I think, is to look at the Marmot beacon indicators in the Greater Manchester report and have a look at whether we could use those to measure progress. And the Wellbeing of Future Generations Act asks us to think in terms of short-term, medium-term and long-term. And I think in this context, short-term is probably the next 18 months or so. Medium-term is probably the programme for this government, and long-term is where can we get to by 2030, which isn't really long, it's not intergenerational, but I think being practical about timescales people can work with, I think that's probably where we are. And in the short term, I think we'll be talking about measures of system change and also measures of equity of uptake of things like screening programs and smoking cessation. I think the medium to longer term is change in measures of things like premature mortality. There are very hard measures of this that we can use, but it's coming back to that logic diagram about if that's what you're trying to achieve, what are the root causes, and then making sure we've got the measures in the early stages of those root causes so that we know if we keep going, we'll get to where we're trying to get to. So it's a bit of a speech, but I hope it makes sense.
Thank you.
Pippa and then Tiege.
Thank you. I was really interested in the whole school approach, and I'm wondering whether or not there's a little bit more work that we can do around the kind of reimagining of the school day that's going on at the moment. And I'm sure you won't be surprised that I want to link physical activity to mental resilience and well-being. And I wonder if there's something that we can do more in this space. Is obviously that links into the obesity strategy and the healthy weight work as well. But there's something around increasing levels of physical activity. And I guess I'm differentiating between physical activity and sport there, where activity is just simply being active, and whether or not we can perhaps use the new PSB to try and influence the increasing levels of physical activity within school, as well as active travel to school, which of course is something that you've mentioned. So they were just a couple of things that really popped out for me. And I just wondered if there was more we could do in that area.
So if I could pick up on physical activity and mental well-being for the population as a whole before I come to schools, it is one of the 5 ways to well-being, which has been core to all of the reports I've written consistently, because I really do believe that they're very easy to do. And the point about the 5 ways is you need to do all 5. So lots of people are doing 2 or 3, but it's putting all 5 together that has the impact on well-being. So the part of the report that talks about mental well-being and the investment in the foundation tier, there's a lot of activity in there on the 5 ways to well-being, and my team are launching a 5 ways challenge for the summer to exactly do what you're suggesting, Pippa. In terms of a whole school approach, the alignment with national programmes is one of the things we need to achieve here, because the Welsh Network of Healthy Schools is a Public Health Wales led national programme that sort of comes with this is a bit of a manual in terms of this is what you need to be doing, and I think developing the scope for keeping the core of the evidence says these are the things that work, that do need to be described nationally, with the local flexibility to fit in with what we think the opportunities are locally, is where I would hope to get to. And I mention that because there's quite often a wish to put on a drama to do something, or an activity. Assemblies are always a good one, aren't they? And on their own, they have almost minimal impact. That whole school approach to promoting health and well-being has to be core, to which you can then add specific bits of curriculum to address particular topics. But so it was in the original Building a Healthier Gwent report a couple of years ago, there was quite a section in there about a whole school approach. So I was really pleased to see Welsh Government's framework promoting a whole school approach to mental wellbeing, because I think that is the foundation on which everything else then sits.
That's great, thank you.
Thank you. Tej?
Thank you, Chair. Sarah will know that I'm very enthusiastic about this document. Those of us who've worked in the third sector and the advice sector for many years would, our Christmases will come together in seeing this sort of pulling together of the agenda. And we have, in Wales, we have recognised this for many years. Welsh Government supported the Better Advice, Better Health project back maybe 20 years ago. So we have known for a very long time that the wider determinants of health, socioeconomic issues, completely align with health inequality. So I'm really pleased that everything has now come together, that we are in a position that we have all of our partners aware, and that the future generations agenda also aligns. And on that subject, and aligned to the public service boards, obviously all of the public service boards have their, currently in our area, have their wellbeing plans, and all of those include public health or population health parameters. But I would really like to see that as we move forward to one public service board, that this document is front and centre of that more strategic approach, obviously to be discharged at local authority level in consistency with local dynamics. But to me, this is the perfect document to be that central core. So I'm very, as I've said before, I'm very enthusiastic about this, and very pleased to see it, be part of a central part of our work going forward.
Well, the chair will probably want to add her own comments, but I think the leaders of the local authorities are really wanting to do this.
Yes.
Which is why I think there is a real opportunity. I guess I'm pragmatic enough not to be suggesting there is, just because planning timelines align if hearts and minds aren't in the right place. But I do think the leaders really do want to do this. They were incredibly supportive when I published the report and held the conference. I think they're keen to pick it back up and give it leadership. So I'm optimistic.
Yes, I would endorse.
Chair and Judith are going to tell me otherwise.
No, that I would endorse. They in the guise of G10, they were very enthusiastic about endorsing this and putting the weight of their organisations behind helping us collectively to achieve some real improvements in the goals we've set ourselves. So I think this is a very good starter for a new PSB for Gwent, myself.
And the Chief Constable and the Police and Crime Commissioner are equally very enthusiastic, as you would expect, Natural Resources Wales, and actually the Chief Fire Officer has been a huge support all the way along. And of course, Fire and Rescue Service are the example in terms of shifting from response to prevention. So I think our PSB partners do really get this, and they want to make it happen. And I think we're all realistic enough to know that it's not going to be easy, but I think there is a mood of, well, let's give it our best try, our best effort.
Thank you very much, Sarah. And we will obviously monitor this very, very carefully. at various intervals in the board to see how we are making progress and what we can actually achieve within the timescales that you've outlined. So thank you for that. Could we move to urgent care transformation, Rhiannon, please?
Yeah, thank you very much, Chair. So I'm presenting this paper on behalf of Nick Wood, who's the Director for Primary Care, Community and Mental Health, and he's the Chair of the Urgent Care Transformation Board. And the report is for information and assurance, but an important item in light of the Health Board performance and patient experience and outcomes and the ongoing system pressures that we have. We heard earlier in terms of the annual plan, and as part of that, urgent care transformation is one of the 10 priority programmes, and as such has gone through a reset and refocus. Some of the programme principles include this being a whole system response to emergency and urgent care pressures, that managing demand and support for patients to access services in the right place first time is key. The delivery of care closer to home, which is a key principle in terms of our clinical future strategy. Our home is best ethos for patient transfers and care delivery, and supporting services to deliver care in the most effective and timely way. So the paper outlines the governance structure for the Urgent Care Transformation Board, really stressing that this is whole system. That's shown on page 3 and identifies the key 3 work streams that we've got, which is 24/7 urgent primary care, emergency care improvement board, and the graduated care model. And within those 3 work streams, we've got the overarching objectives, which include the improvement in emergency department performance and additionally the delivery of the national emergency department quality and delivery framework objectives, improving primary care performance and the effectiveness of 111 First, improvement in hospital length of stay or time away from home, both in the acute inpatient areas and community hospitals, really embracing the perfect ward principles. Improvement in patient experience more broadly and their outcomes across the urgent and emergency care pathways. Reviewing the full range of appropriate system-wide data for service improvements is very much a data-driven improvement programme, and where we see improvements based on best practice evidence and, importantly, the patient voice. For each work stream, it's got its own objectives, and they've been outlined in the report. So I wasn't going to go into those in detail, but just that those objectives and the performance against them is monitored in this new Urgent Care Transformation Board. There have been 2 meetings to date, and I think it would be important to highlight that already we're seeing an enhanced sophistication to the data and the information being received in that board, which is enabling targeted attention in a number of areas. I think whilst the report on urgent care transformation is for assurance, it would be really important to highlight the significant challenges being faced by our system and for patients and the public currently. There have been an inordinate increase in demand for urgent and emergency care, way beyond our predictions. We talked earlier about the pressure in primary care and mentioned the 20% increase in demand. And we've regularly reported the pressure on the emergency department and, of course, our assessment units, with demand greater than levels ever previously recorded, and notable pressures for cardiology and emergency surgery very evident. It'd be important to highlight the acuity of patients presenting, which is notably higher, potentially attributable to latent demand and the impacts of COVID, which is having a direct impact on our length of stay. And additionally, patient dependency is higher. We've recorded the highest number of patients requiring enhanced care in our hospitals. The staffing challenges are also significant and they continue. We've got increasing sickness levels, absence rates, and anxiety is in the top 3 of the rationale for absence. Self-isolation, as has been notably recorded and reported in the media, is having a significant impact on services. And this is mirrored, of course, in social care and the independent sector. And we've had 22 care homes across our footprint in COVID incident mode. We have very high numbers of patients deemed clinically stable to transfer to their next destination of care who remain in our hospital beds. So that just gives an overview of the current significant pressures that we're facing and the impact this is having. Board members will be aware that Welsh Ambulance Service have also been in high escalation, which has impacted on their ability to provide timely ambulance response across Wales. This will, of course, result in a number of serious incidents and will impact on patient outcomes. So our health board, like others in Wales, have been in a continued state of high escalation, and our services are under immense and sustained pressure. Our response needs to be in the here and now to mitigate the risk, whilst also ensuring a firm focus on the medium-term actions to improve urgent and emergency care on a sustainable footing using an evidence-based and data-driven approach. Some of our here and now aspects are described on page 7 in terms of our daily operational meeting described as command and control. I am aware that some people have got antibodies to that description, and I completely understand that. That command and control is not reflective of our leadership style, but it is terminology associated with the programme management approach that's been deployed. It's a rapid meeting to determine critical safety issues, actions that we need to take to mitigate those, and the identification of small tests of change led by frontline practitioners. Some of the metrics included within the report illustrate some of the small improvements that we're already beginning to see, and particularly the time a patient is deemed ready, ED ready for discharge or transfer, and a reduction in that time, and additionally the reduction in the longest waits within the department. We're continuing to actively monitor the situation in terms of delayed handover response and the impact for patient experience for those patients waiting in the ambulance, but additionally and importantly, the inability to release precious ambulance resource back into the community to respond to Amber 1 and Red calls. The approach to command and control has actually been really positively evaluated by the attendees, describing it as empowering and informative. But this has now moved to 3 times a week, and we stand it up on weekends if the pressures dictate. We've also agreed that the command and control description will now be amended to align to the escalated arrangements that are now being stood up again as part of our 3rd wave response. Some of the more medium-term actions include the introduction of same-day emergency care, SDEC, which enables care and treatment in day for patients who have urgent care needs but don't necessarily need to remain in a hospital bed. It's with rapid access to diagnostics, for example. The SDEC will assess, diagnose and treat eligible patients before safely discharging them home to recover or to wait for further investigation and intervention. Whilst predominantly outlining our approach to the urgent care transformation, the report also mentions the predicted winter picture to include COVID, RSV, which is a respiratory illness in children, but that also affects adults, and of course flu. Our winter planning has commenced in earnest. I'd like to thank you, but just hope that the report provides a summary of the assurance. But of course, myself and colleagues will be happy to take any questions. Thank you, Chair.
Thank you, Rhiannon. That was very clear. It's a very, very significant and serious problem that is affecting the whole of the system that we are trying to operate and our patients. So I'm grateful for the work that you and the teams are doing to try and unravel some of the problems on our behalf. Are there any questions or comments to Rhiannon? Louise?
Hi, thank you, Chair. Thank you, Rhiannon, for that report. I'm just wondering. I know we know the percentage of walk-in patients into the Grange and into our other units and everything. I'm just wondering, do we know the percentage of walk-in patients that present at GUH, which have not accessed the GP or the 111, and therefore have not gone through the flow centre or the hub phone first? And are we collating that information as to why they're not doing that? I didn't see it in the report for that. I've seen the numbers, the percentage numbers, but not a more deep dive sort of evidence as to why they were presenting.
Okay, thank you, Louise. And I think that's a really important point to highlight. We're collecting oodles of data in relation to presentations, both in terms of those that arrive via ambulance, but also those self-present, both in terms of the emergency department, the assessment units, but also our minor injuries units. We do collect information in terms of why people will self-present, and probably important to highlight that in times of escalation for Welsh Ambulance Service, whilst they might not be able to deploy an ambulance in a timely way, we will then see subsequent increase in self-presenters and people who attend on their own merit for the very reason that they require urgent and emergency care. We've also worked with the Community Health Council and the person-centred care team to undertake patient experience surveys to understand why they self-present, why people have attended, and the routes that they've taken prior. And I think that the data that we've got has been very valuable in helping us to improve the response of the flow centre and working with our colleagues, particularly WAS, to ensure that all presentations for ambulance are directed through the flow centre. And we've seen a significant improvement in that since the introduction of the flow centre. Some of the issues of ambulances attending GUH in the first instance, we're not seeing so much now, although there'll be further work on that front. So we've got significant data, but I'll bring Leanne in because she'll be far closer to this in terms of the evidence and the data. Thanks.
Thanks, Ree. It's a great question, Louise, because we can't always rely on some of sort of the anecdotes. So it's really important that we understand how and why people are presenting, and that we've got sort of really good evidence base around that. So we have been undertaking sort of detailed data collection that looks at patients that self-present at the Grange in particular about whether they have accessed 111. Interestingly, when we capture it at a quite a, I guess, a superficial sort of a high level, we get an indication roughly. We separate it by peds and by adults separately because of understanding how we target those different sort of patient groups. It ranges between sort of 40 and 50% is the information they give us when they check into the system. But not content with that, we have been trying to capture the details so we can triangulate with 111 data. So we've gone into more detail again, got individual sort of patient details and reconciled it to the 111 record as well, so that we understand if they have followed the right pathway as well. It gives us sort of really great intelligence. What that more detailed audit has told us is that about only 20% have actually gone via sort of 111 so they're either trying 111 or sort of it's being abandoned. We haven't sort of captured that yet with the patient cohort, or they are misleading us, I guess, in relation to sort of them accessing sort of that service. So there's an awful lot of and some of the command and control sort of process and meeting attendees that we have joins up, I think, parts of the system. So we have our urgent primary care sort of colleagues on there and our ED colleagues so that we can triangulate the data and it forms part of sort of the audit work that we are doing there. So it's an area of focus, I think, just to give assurance that we do have that level of detail and we're feeding that in via sort of the 111 route. Just a few more points, if I might, just in terms of supplementary points to the really comprehensive update that Rhea has given, just in relation to reassurance around, I guess, sort of the use of the term command and control, and just again to ensure that people, I guess, assure you that how the meetings are run. We always finish the meetings with, have we lived the values and behaviours of the organisation in it throughout the meeting in going about of our business of the meeting, and complete sort of the meeting on one thing to be proud of. And I think that's really, really important given the sustained pressures that sort of people are under as well. And also, I think, just to ensure that our staff feel well supported and particularly given sort of the sustained pressure. And I think just as a supplementary point around the ambulatory care, the same-day emergency care work stream, we know that that is a significant sort of piece of work for us, that if we can develop that model of care, that ethos of care, if I use a very detailed pilot that we've done, the surgical ambulatory care sort of unit, over 80% of patients we believe can be dealt with via the ambulatory care model. And that would decongest lots of our sort of inpatient or assessment areas if we're able to sort of provide that in another way. So as Ria's already said, lots and lots of sort of multiple work streams that tries to balance the immediate significant pressures that the whole system is under, set in the context of some of those workforce pressures, alongside the medium to longer term sort of improvement.
Thank you, Leanne. That was a very helpful explanation. Emrys?
Thank you, Chair. I think some of my questions have already been answered, but I just want to add, if I could just add to it. Obviously, it's noting the demands that, first and foremost, the plan, it asks in the paper about views on the approach. From my perspective, it's the right approach. Sorry, and I wouldn't undermine what you're doing in respect of trying to manage this demand. I suppose the key thing for me looking on it is about the importance of data to help inform on demand. So one of the questions, I suppose, or the broader question is, the demand that's presenting at GUH, is that real demand for GUH? And it would seem it may not necessarily be that. The second thing then is that it's recognising this demand that this extra demand that you're having to manage. You know, the numbers aren't usual, it would appear. You know, we've got latent demand, we've got people with increased acuity, we've got enhanced demand that's going to have other sort of specialist input, I suppose, and then we've got winter coming as well in the short term. It's just being clear that we have the data that we're receiving is helping us to inform the types of care that's required and where we need to be focusing our actions. And my other point is that obviously our local authority colleagues are also experiencing similar to us as well, and they have, and I could see that there was a number of homes that are affected as a consequence of COVID and the like. And I mean, there's so many issues here. And then the other, I don't want to keep on labouring, adding on, but then you're having to use other capacity, which would be used for something else so that you can respond to the needs. There are so many things going on here that as you're having to try and, working hard to keep on top of, and it's the risks associated with that. And I suppose going forward, we just need to, and not to state the obvious, it's just to be assured that we have those risks shared as we're going forward, coming up to winter as well.
Thank you, Ray. Thank you, Emrys. Are there any further comments? We note the intense work that is ongoing. I think it'd be really helpful for the next meeting if we could have, in addition to this, an analysis of whether the emergency and urgent care system is working as was planned, and how far away we might be from that. It would help set the context, I think, for the board. But we appreciate the real difficulties being faced by both patients and staff in trying to manage this real upsurge in genuine demand for our care. And thank you for the work that's going on at Leanne and Rhiannon. Thank you. Can we move to the Grange University Hospital reflections on the first 6 months? Are you taking this, Chris?
Yeah, I'll introduce it, and then Leanne may well want to comment. There's a lot in the paper on there about urgent care, so I don't want to repeat the previous item. But I think it's important that we reflect on some of the wider benefits of the early opening of the Grange and some of the information that's captured in the paper, particularly around staff and patient feedback, and that really important richness of views and the ability that we've had to respond to staff and respond to patients. So one of the really key benefits, and I think we need to say this, we don't say it enough times about how we managed to open a hospital early in the middle of a pandemic and the significant achievement of that. But really what that enabled us to do was to really be able to get through the winter, and a very difficult COVID winter, with the ability to adapt our estate to meet the needs of the COVID demand, and our ability through the quality of the estate in the Grange to establish really successful intensive care services, and also the quality of the estate. And I think it's really written large in the infection control information in the paper that because of the single room environment and because of the quality of the estate, the impact that made in terms of hospital spread of COVID and the quality of the estate that we had in the Grange. It's also important the benefits that we've had in terms of our increased diagnostic capacity and the additional opportunities we've had afforded by the Grange, as well as that experience of once people get into our system, and we've talked about some of the urgent care pressures, the co-location of some of the diagnostic equipment, the access times to theatre, and the ability to have that co-location of staff around complex cases is really seeing significant improvement in outcomes for good outcomes for our patients. It's also had that positive, although position on recruitment, with 241 new posts recruited as part of that opening of the Grange. So really strong on that basis. And then just to touch on that staff element, what was the challenge in opening early was the ability to have that time to do the cultural development with staff around how you move, multiple teams to a new site. And actually, what we've seen and what we're increasingly seeing in over this last 6 months is actually, and you'll see it in the feedback from that staff, about those benefits of co-location and bringing teams together, and that experience of working in a really good environment with that additional space. And also you'll see our ability to respond to the questions from staff. So that big focus on how do we meet the wellbeing needs of staff, and the work that we've developed around the sleeping areas, the brilliant pods that are now outside. If anyone who's walked around the Grange recently, there's some fantastic outside space for staff to sit, reflect, and have that enjoy that environment. And we're still working through in terms of responding to the requests from staff around how we improve communication and how we support that cultural development of teams who've come together in the Grange. And then importantly, in responding to patient feedback, and you can see again in the report that really positive benefits of that really new and refreshed environment and really positive experience people get from the state of the estate that we're able to put people in. We've already made those changes to improve the Wi-Fi. I know from having been up in the Grange last week that my mobile phone now works up in the Grange through being able to put in the new masks to improve signal there, and that access to televisions and improving the environment as well as that improvements we've made in the quality of food on the site. So I think it's a really positive report that reflects some significant system benefits from opening the Grange that take us beyond, yes, we know there are urgent care pressures there, but actually some of the significant benefits of opening the Grange early are reflected in the paper, but also our keenness and our ability to respond to patient and staff feedback. I don't know if Leanne, you wanted to add any more?
I think it's just to reinforce the point that you've made in relation to sort of the single rooms and the ability. There is absolutely no doubt for me that I think sort of with us being in the second surge, we would have coped as well as we did, in spite of the fact I think the pressures were significant sort of all round. Adding a system reconfiguration into the mix, I think, was absolutely the right thing to do. As I said, with those single rooms and our ability to continually assess demand and be able to flex the system to meet patient needs and requirements was, I think, sort of a massive benefit for us during a very difficult time.
Thank you, Leanne. Paul? You're on mute.
I said the excellent report and excellent update, and the feedback I've got from members of the community who've actually been in the hospital for various things has been incredibly positive, and I think we should I think we take on board what we were in the middle of the pandemic. It was opened early, it was on budget. I mean, it's incredible work that's gone on there, and I think the statistics and the information is incredibly useful reading. There's just one issue, and the issue we have still got to work with the community over is access. There are people going to the hospital who shouldn't go to the hospital. So there's still a piece of work. The community don't seem to understand or not sure. There's still some issues there. I've anecdotally, ambulance are saying, no, if we want us to take you, you've got to wait an hour. Or 111. Well, if you're really worried, go to A&E. So there's all these issues there, and I'm not quite sure that we have addressed. They may well be being addressed, but there may be. I think there's a lot of work that we may need to do to make sure that the original function that was proposed for the GUH, that if that's the sort of the model we're looking at, that we continue to work at that. But there is still some work I think we need to do to try and explain the whole concept about what is available locally to people, to make sure that they sort of understand the sort of the structures that are now in place within Gwent. And I'm saying that in a very positive way, because that's the message that's coming through to me from members of the community, that they haven't quite got on board. They used to go into the Gwent when it's an accident emergency. Now they think, well, I'll pop over to the Grange then. And then, whereas we're looking at referrals, really, that's the route. Is if there's an emergency, then for that. So I think there's some, the 6 months on is great, but I think we may need some regular updates about what are we doing to ensure that patients and the community do understand what the whole operating model of the Grange was when it was originally proposed. Hope that's helpful. But I think I've just felt it needed to be said.
Who would wish to respond to that?
And would you mind if I came in on that? I think just a couple of things I'd just like to add, really. Some of our experience and feedback from Northumbria was that they saw a 20% increase in demand when they opened. So I think we have to also bear that in mind. I think there will be a natural, I'm sorry to say it, curiosity factor, which I think is not necessarily very helpful given the pressures we're sustaining at the moment. But I think we should bear that in mind in addition to all of the other pressures that we're experiencing. And I think just to provide you with some assurance, Paul, there is an awful lot of work going on in relation to sort of public messaging on individual patient level and also at a system level in terms of people accessing our system, and will continue to do so until we believe that we have routed patients to the right place. I think it's fair to say our system is pretty unique in Wales. It is important to remember that because of the separation of the specialist and critical care centre, which is a means that sort of people accessing things like 111 normally sort of the normal algorithms don't really sort of apply in the same way sort of to us. So we're doing some work to ensure that those pathways are very well understood and also sort of are in place. Some of this is down to the fact that we aren't necessarily fully back at some face-to-face sort of consultation. So on the basis of the clinical information we have at the time of either sort of referral in, it's appropriate that they would go to the Grange, and it's not until we've done sort of the review of the patient afterwards that becomes apparent. So we have, I think it's fair to say, a multi-pronged approach in relation to sort of getting this right. It's partly communication, it's partly our pathways. Ree's already talked about compliance, I guess, working with WAST around Flow Centre. And I think that the fact that, again, we have a very unique model with the Flow Centre, we have the ability to take more within our control from a health board perspective to ensure that those pathways that are different to the rest of Wales can be implemented. So completely agree with you. There is lots of work to be done across the whole of the system in relation to this.
And I think if I can follow that up, I mean, I think the regional partnership board, could well have a part to play in, again, putting the messaging out. And I know the communication team is doing and has done a terrific job in communicating. But I think that, when you've got sort of issues with regard to accessing the GP, 111, the ambulance service, it is a perfect storm developing, and people thinking, well, actually, I'm going to go straight to the hospital. So I think it's those sorts of things, and we've got winter pressures coming up. So we just need more conversations on that, really. But thank you for the response. I think you've reassured me to a certain degree, but we've got more work to do, I think.
Thank you. Sarah and then Shelley.
Thank you, Chair. I just wanted to reiterate the point that Chris made around the tremendous effort in terms of individual staff and teams in opening the Grange early, and the positive workforce aspects. It's really positive to hear that feedback from staff, but just to recognise that there is more work to do in terms of recruitment and retention, and more work to do in terms of team resilience and well-being, which you would have all seen evidenced in part of our work programme as part of the annual plan.
Thank you, Sarah. Thank you for that clarification. Shelley?
Actually, it's something Sarah said, if I can come back on that in a moment, but it was just a follow on from what other colleagues have said. I wonder, Anne, if we perhaps as a board at one of our committees could have more information about the analysis behind where people are attending from and what work is going on. I know that SD, I can't remember, same day emergency same day emergency care. I mean, I don't know whether that was planned first, if that's new, how that will change the dynamic in terms of the hospital and all of that. So I wonder if perhaps not obviously now, but could, perhaps we at one of our committees, we could have a bit more of a look in a bit more detail to understand what this is and the impact it's having on not only GUH, but everywhere else. And if that's okay. And then the other point Sarah was just making there about staffing, I was going to ask, and it's not necessarily for today, but again, I'd be interested to know, I know we've done very well in terms of recruitment at the GUH, and it's all that, and I know in terms of our overseas nurses in post, that's fine. What I wondered though was, what is how many external people, if you like, have been appointed to work at GUH? And how many people have moved from other areas within the health board, and the impact of those particular people, I think, in terms of the ability to deliver services elsewhere, if you know what I mean. So, and again, this may be something more for the people committee, but I think it would be interesting to understand what that dynamic is within the system, because obviously we still do have gaps, and obviously those have to be filled, as we've heard elsewhere, despite the efforts in terms of recruitment.
Do you want to add something, Sarah?
I think in terms of the analysis, that's something we could take up with the People and Culture Committee. There has been a blended approach of internal and external recruitment, not only for the Grange, but then making sure that we backfill any vacancies that we needed to across our system. Thank you for that point, Shelley.
Thank you. Rhiannon?
Thank you. And just to add to that, Shelley, I just wanted to highlight what we've now got, which is a different risk. So previously a high risk was the volume of vacancies, and there's been tremendous work, as the board are aware, in terms of reducing that number of vacancies and limiting the risk as such. But now the different risk is either an workforce that are not familiar with the health board and the health board processes, but additionally in terms of the overseas nurses, but also new recruits, we've got people that are generally quite novice in our workforce, and that requires a different level of support and pressure amongst other members of the team. So we are cognizant of that, and as an executive team have supported the employment of further practice educators to support those novice staff to get to where they need to be over the next year. But it's just interesting times in terms of addressing the vacancy gap and now having a different risk associated with that. So a constant challenge. Thank you.
Thank you, Rhiannon. Are there any more comments or questions? In terms of the evaluation, Shelley, I've asked Nicola to present a report to the next meeting of the planning committee, looking at the evaluation against the model and where we are, and the indices against which we planned this system, and where we are with that as well. So we'll get a more comprehensive view of what the next steps might be, and that'll be coupled with the urgent and emergency care work that is ongoing, which is vital to inform that sort of discussion. So that's that is she is preparing, and also a more systematic evaluation of the staff and patient feedback that we're getting, which is ongoing and really important. because it will allow us to tweak the system if it's necessary so to do. And the improved outcomes, obviously. So that is for the planning committee to discuss next time. Thank you. And thank you all very much indeed, for we all know what a tremendous effort it was to open a new hospital early in such very difficult circumstances. And we're really grateful to all of you for everything that you did and the thought that went into that and the energy. It was really impressive. So thank you. Can we go on to strategic risk, please?
Thank you,
Richard?
Chair. Yep, this report is for assurance for the board in terms of the ongoing work that we are undertaking in regard to the revised risk management approach, which has come through this board, I think, in May, and the amount of work that's been undertaken, and also some of the planned developments as well that we have in store for the future. But I think rather than actually going through the report in detail like that, I think I'd like to say, in terms of the approach that we are taking, I think listening in today, I'm encouraged that actually it seems as if it's being inclusive in terms of being included within the decisions and discussions, and I think Chris alluded to it earlier on in terms of the annual plan. That was on a risk-based process, and the links into the data requirements, and I think that's I wouldn't say testament, but that actually links into what we're trying to attempt to do with the risk management approach, is actually get people to think about what it means for strategic and operational planning and delivery, and using the data to actually inform us better and to actually provide better ways of trying to predict threats and the issues as they come up. And so I'm quite encouraged with that today. So and I think it shows that we are actually trying to embed this system across the organisation as a whole. We know that this is just the start, and a lot of these risk profiles that we're trying to create will be refined during the year, and they will change. And we actually expect them to, because the more data and information that we provide, that we are given, the better we can actually predict what those threats are and what the potential causations of some of the events may be. So in that respect, I'm just in terms of the planned work, what we are hoping to do specifically, if you like, is within the next year, look at a digital system for capturing this, for capturing risks, but also, because it's within the DATEX, it's trying to actually link that with incidents. So we're actually linking the data of incidents to the potential risks that we've predicted. And with that, we're actually linking in with our performance colleagues, so that's we can actually try and get an exporting process around some of this data as well, so we can actually improve our decision making. And hopefully, I think from our perspective, you can see this approach can be seen to be of benefit, and that with some integration, and the importance of the Audit, Finance and Risk Committee is highlighted. So we are going to provide a new risk management strategic approach to the August meeting, which will then come back to the board in September. And then in October, that committee will also have the full organisational risk profile, as it will be then. So that will be a mid-term report up until September. So that falls within our agreed processes. And I think I'll leave it there. There is obviously the list of a profile of new risks that we've identified. I hope the format is helpful for everyone, where we've tried to identify what that potentially threat event is, and what will actually cause that event to happen. And we understand that this is quite complex sometimes, we try to simplify it. It's not always a single cause. There will undoubtedly be multiple causes for something to happen, and it's not always going to be one big bang in terms of something's going to happen. It may be multiple small things which will actually create that event to happen. So I'll leave it there, and I'm open to any questions then.
Thank you, Richard. Are there any questions to Richard about the risks in the report? Louise?
Thank you, Chair. I just wondered how we were going to look at addressing some of these risks, especially the one about the inappropriate admissions to children under 18 onto the acute mental health wards. I appreciate we've got processes and guidance and safeguarding in place. I'm just wondering what the long-term sort of plan is to address that, because it seems, you know, quite a emergent area to be covered.
Yeah, I would agree with that, and we need to speak to the operational process and make sure we have some discussions about how we're going to manage that and link in with the regional partnerships about what that means in terms of the availability of the service, because obviously in terms of beds, and there is a regional process for that. I think some of our acute beds for paediatric is in Bridgend, and so we have to have I suppose a discussion with the service around that, how that works, and obviously in my perspective that will be with the operational service rather than myself.
Rhiannon?
Yeah, I can come in on that one. Thanks very much, Louise, for the question, and thanks, Richard. So I think this has been an issue for some time, Louise, that people will be familiar with. Just to assure, we have had some really productive meetings between the Family and Therapies Division and Mental Health with some exec colleagues, Nick and myself, in relation to what actions we need to take from a local perspective in the interim, whilst there's national work ongoing. And again, just to highlight that in terms of the Chief Nursing Officer's office, we've raised the concerns, which are national concerns, about children in this position in terms of availability, capacity and demand. And there is a national work stream which we are feeding into. So national approach, but also some local work to determine a better experience for children and young people who do require admission.
Thank you, Rhiannon. We will watch this carefully because it is an ongoing problem.
We've raised it at the Patient Quality and Safety Outcomes Committee, Chair, and we will be bringing a report back to that committee as well. Thank you.
Good. Thank you. Tish?
Thank you, Chair. Can I ask a question specifically about risk 030? So that's safeguarding incidents. Of all forms. So if I can just have a little bit more information around that and where that's come from, and whether we are seeing a significant reduction in reporting, and is that around that, as it explains there, is it around the reduction in contact given the period that we've had, and also, what are the challenges in respect of training, given the conversation we've just had about new staff coming in? And if we could just have a little bit more context around that, please.
Great.
Thank you, Chair. Thank you, Tish. I'm happy to provide more detail outside of the meeting as well, but just to provide assurance, there's a lot of work in this sphere. I think that the board development session we had recently outlining the full range of the safeguarding agenda highlighted the significant work. The risk itself was particularly associated with the pandemic and lockdown response, Tish, and our own response. So one of the lessons we learned from the first and second surge was where we deployed staff, particularly health visitors, in the first surge. We did not do that in surge 2 because we recognised the impact that lockdown was having on the risks to children and adults that were unseen, so not in school where we would have ordinarily seen reporting. It is nationally recognised that there has been an increase in referrals as a result of the pandemic. Those are being managed and seen. And then just to pick up the issue in terms of training, we have got quite comprehensive records of our training compliance. We've highlighted areas where there's good compliance and areas where we need to secure additional attention. But what we're recognising with the demands that we currently face is that's a targeted approach. So, for example, we've linked in with James, Medical Director, in relation to concordance for training in relation to medical colleagues, but also estates and facilities staff. Facilities staff would be deemed to be a higher priority than our focus on estates, for example. So we're taking a risk-based approach to the training, and the issues of compliance was associated with training. But again, just to highlight that we've got very good training compliance for adult safeguarding and children despite the pandemic, which is important. But I can provide you with further information, Tej, if that would be helpful.
Thank you. I would appreciate that. And also just to a point to note, and I know all colleagues know this, but clearly absolutely appropriate that in respect of the risk appetite, our on this register, our appetite is very low.
Yes. Thank you. Shelley?
Thank you, Anne. My question is really for Richard. It was just, I noticed now that obviously there are 25 threats you've put on the report, and I'm not sure whether these 8 are an additional 8 or that's included within the 25. But so that's the one point. But the other thing is, without seeing the rest of the risk register in terms of the whole risk register, what I would be interested in, and I'm sure it is happening, some of these risks there are elements of them that I recall from the risks we've seen before. So I assume what's happening is the risk profiles are being re-looked at so that we don't have an overlap between different risks. You know, if there is specific risk, I'm thinking the one particularly in staff absence and ability to perform. I think that might have been just part of a previous risk in relation to workforce. So I'm assuming there will still be risks in relation to workforce, as Rhiannon has pointed out. But this is a new risk. I mean, I'm sure this will come out in the more detailed report we're going to get at the committees, but don't know if Richard can help on that.
Yes. So these are new risks, and what we're attempting to do is, in line with the approach, is to actually develop these profiles. So we will have workforce profiles, which will be some will be based around absence, some will be based around training and capability. So rather than having a great big long list of different individual threats and or risks, which then will have a long over 100 individual risks. We're trying to actually create, like I said, what we call as risk profiles, where we have amalgamated risks around specific subject areas.
Okay, thank you for that. I think, I'm sure we can discuss this in more detail in the committee.
And the full list will actually come to the Audit, Finance and Risk Committee as well, and then also it'll be referred on to the various other committees for the individual risks.
Yeah. Okay. Thank you very much.
Okay. Thank you, Shelley. Any further questions? Okay. Then this report is noted. The finance report. Glyn.
Thank you, Chair. And I'm conscious that we will have covered some of these issues earlier on when we agreed the delegation of revenue budget, so I won't go over those again. Probably just to report that at this stage, based on some of those assumptions that were made, we're currently reporting a balanced position at the end of the first 3 months of the year, and obviously the forecast financial balance again assumes a level of funding which is yet to be confirmed by Welsh Government. 3 points that I'd like to draw out of the report, if I can, in particular. The first one is around what we're calling sort of recovery. The board will be aware that we received an allocation of about £17 million from Welsh Government to implement additional recovery plans, particularly around recovering routine elective waiting times. This was part of a national funding allocation of 100 million. At the time, it was described as the first tranche of recovery funding. In terms of our use of that allocation, we have committed plans that would cover the 17 million, and most of those plans have been implemented during June and July, so we would hope to start to see the impact of some of those recovery plans in terms of waiting times. However, I think it needs to be understood that the increase in demand, underlying increase in demand, is such that I think it's going to be a while before we see some of those waiting times actually come down. So that is probably an important point to note, and I'm probably mixing some of my messages with the finance report and the performance report, but they are very much interlinked there. Also conscious that we've got some pressing priorities around risk of harm to patients, some of which we've discussed earlier on during the board. And so the executive team have also agreed further commitments with regard to recovery around investing in additional endoscopy services, additional capacity to allow patients to more quickly access diagnostic tests for lower GI cancer services, and also to increase some of our capacity, particularly nursing capacity, around heart failure services. So again, these all link back to areas which are priorities for us as a health board, but also areas that we know we're seeing increased demand. And again, our assessment around risk of harm to patients is by doing this, we would hopefully reduce that level of risk. It does mean that we are potentially committing additional money over and above the £17 million. That probably equates to about another £1.5 million. And as a result of that, what we've done is to write an accountable officer letter to Welsh Government to make them aware of those decisions that we've taken, the basis on which we've made those decisions, which I think is absolutely right and proper, and obviously the potential financial risk that comes with that. But again, I thought it was important that we brought that to the board's attention. It's a decision that we made fairly recently. The second area that I just wanted to cover off, it's in the report, was to bring to the board's attention the underlying financial position. So this year, I think, as I mentioned before, it's going to be a year of uncertainty. A lot of the funding that we've received is to support a lot of one-off expenditure in response to COVID or the consequences of COVID. So as we move into future years, and hopefully we get back to some sort of normality, the expectation will be that we then start to live within our recurrent resources, recurrent funding. Based on our current assessment, we would have an underlying deficit position of about £20.8 million. And in the report, you can see how that's moved over the last 3 or 4 years. So we initially saw an improvement in that. It then worsened in the last year or two as we made decisions about investing recurrently in the Grange University Hospital and the LGH network. It also included some digital investment, but also it reflects the fact that last year, when we were going through the pandemic, the level of savings target that we'd set ourselves, we weren't able to achieve because I think quite rightly our focus was on responding to the pandemic. So that lower level of savings recurrently means we need to address that position going forwards. That links into the next, or the sort of final area that I wanted to cover, which is around savings and efficiencies. Again, the paper sets out where we are and where we need to get to. So again, still further improvement required, but we will be taking a more detailed report to the Audit, Finance and Risk Committee in August, which looks at the underlying position, the savings plans that we have in place that we think are deliverable at the moment, and then looks at the range of savings and efficiency opportunities that we believe exist, linking it very much to where we see some of our priorities going forward. So making a link with the annual plan and some of those key priorities. So I just wanted to draw that to the attention of the board, because we will have a more detailed session with the Audit, Finance and Risk Committee in August. So finally, I just wanted to ask the board to note that this report is very much for assurance, noting the position, but also the forecast for the rest of the year. Clearly, there's a range of risks and opportunities that we're trying to manage as we go through the year, and also to note the performance on our public sector payment compliance as well. So happy to take any questions. Thank you, Chair.
Thank you, Glyn. Are there any questions to Glyn? We will, of course, have the opportunity to discuss the more detailed report at the Audit Committee in August. And we note the very difficult position that we have in terms of being precise about the monies and their availabilities at the moment, because of the uncertainty that Glyn has explained to us. So if not, then could we move to the performance report, which links into this?
Okay, thank you, Chair. And again, I'll try and keep this brief because I'm conscious that a lot of the key performance areas highlighted in this report, we've already talked about previously around urgent care, emergency care, cancer care. So again, I won't go into detail now. Again, I just wanted to draw the board's attention to the fact that we are now implementing a range of elective and diagnostic recovery plans. We have a board briefing session again arranged in August. It feels like it's going to be a busy month, actually. But we have a board briefing session there where we will look to run through in a bit more detail some of the restart and recovery plans that we are implementing. And again, importantly, link it to the risk of harm to patients. So one of the things that we will introduce into probably the performance report for September is an analysis of some of the patients who are waiting on some of our waiting lists, and the risk assessment that's been undertaken. Chris mentioned earlier the Royal College of Surgeons guidance on assessing risk of harm to patients, and we've used that to review most of our sort of elective and diagnostic waiting lists. So we'll have a board briefing session on that to talk through it in detail, so that hopefully people can get a good understanding of how it works, and then we'll bring it into our performance reports in September so that we can sort of track that on an ongoing basis. So hopefully that will be helpful. The restart and recovery plans include areas like endoscopy, and again, very conscious of our cancer performance. And you'll see that the more recent performance has improved to just over 70%. I think we will probably see that performance fluctuate a little bit as we deal with the ongoing increase in referrals to a range of cancer services, but also our ability to make sure we've got the right capacity and services in place to deal with that. And some of that links back to some of the decisions that we made as an executive team to commit to recovery plans around improving diagnostic testing, increasing our endoscopy capacity. So hopefully the board can see that as an executive team, we're trying to respond quickly to some of these areas that we know potentially could impact in terms of harm to patients if we don't respond quickly. Those were the broad areas that I just wanted to sort of cover, but again, I'm happy to pause there and take any questions. Thank you, Chair.
Thank you, Glenn. And I think I speak for all the board to say that we would absolutely endorse the concentration on harm rather than time at the moment, although we have to be careful how we manage the time issue.
Absolutely.
Are there any questions? No? Okay, thank you very much. The executive team report, Judith, please.
Diolch, Chair, thank you. Yes, so here's the executive team report, which highlights to the board some of the things that the executive team have been involved in since our last meeting. As you'll expect, trying to select the things to go into the report without making it too onerous is quite a challenge, and certainly trying to pick which things I highlight to you in terms of the presentation of the report also is quite a challenge as well. Just to start with the COVID-19 update, I'm not going to reflect too much on that because we have made reference to it multiple times during various items on the board's agenda this morning. But I think just to remind everybody that we are still operating in a COVID secure environment. And in terms of the number of patients in our hospitals, which seems to be the measure of how under pressure the NHS is, all the same requirements in terms of infection prevention control, patient testing, staff testing, community testing, response, max vaccination, etc., are still in place. What we also are, though, is now seeing a third wave of the pandemic, which is very different to wave 1 and 2. So in the third wave, we're not only dealing with COVID-19, but actually the consequences of what has occurred as a result of the first and second wave and the pressure on services across the health board. We've talked a lot about emergency and urgent care, but the same applies to referrals into our adult and child and young persons mental health services, our planned care, requirements for diagnostics, our cancer demand, as Glyn has just referred to, is increasing across the board. So the third wave is very different to the first and second wave, very challenging for everybody. And clearly for our workforce, they've been through challenging times, both professionally and personally. And so making sure that we're continuing to focus on their well-being is absolute paramount. In terms of other items in the report, the COVID innovation study I've highlighted with the link. If board members haven't had the opportunity to look at that, I would encourage you to do so when you've got 5 minutes. There are lots of examples in the report drawn from across Wales in terms of some of the changes and innovations that we saw during the pandemic's wave 1 and 2, and some really great examples from our own health board area. On page 3, I've included a short paragraph about the joint executive team review. So this is the sort of annual review between the executive team, Andrew Goodall and his team in Welsh Government. And attached as a embedded document is the letter that Andrew sent to me following that meeting, highlighting the conversations. I'll leave that for you to read. A couple of other things just to mention. On page 4, we've just highlighted the closure of a branch surgery. That branch surgery has reopened, but I just thought it was useful to just say we are balancing risk and access across our system. And so we had a particular issue with a branch surgery in Markham that we had to close because a lot of the staff were self-isolating or unwell. And thankfully, with the huge efforts of the primary care team and the practice team, which is a managed practice, the surgery practice reopened, but that's just an example of the sorts of pressures that we're experiencing across the whole of the system, not just in our hospital system. We launched the Race Equality Action Plan on the 21st of July, great event, MS Teams event with lots of people joining from across the health board area, very successful, lots of positive feedback. and a really great contribution from Jason Mohammed about his own personal experiences. Really good session. More work to follow on that, and we'll of course share it through the relevant committee and possibly to the board at some point. Apprenticeships and Kickstart. I wanted to highlight this because we are now going to be launching our Aneurin Bevan apprenticeship offer, but also in the third paragraph under that promoting employment opportunities, you'll see reference to the Kickstart scheme. We had submitted a proposal to host 30 placement opportunities, and we have now received formal notification that our application has been successful, and indeed we will be hosting twice that many, so 60 individuals will be joining the health board through that really important part of supporting our offer to the community around recovery and trying to get work opportunities for people to join us in the health board. I'm personally very excited about that work and really grateful to the workforce and OD team for getting us into this position. Nothing more to say really. There's so much I could say and so much more to comment on, but just to highlight the work, and we'll continue to provide and this update report for as long as the board finds it helpful. Thank you.
Thank you very much, Edith. And I think it's a very clear analysis of the range of the responsibilities that you're covering at the moment as a team. And congratulations on having such a good response at the end of your year-long review with Andrew and his team. Pippa and then Paul.
First of all, I want to say please keep sending the report. I personally find it really useful to understand the kind of background around what's going on. And the other thing that I wanted to pull out, it's not a question, it is a big thank you from me around the consultant induction programme, because it's something that I feel has been missing for some time, that we need to support our new consultants as they take up a new post. And I feel that up to now it's been quite informal support. So I just think it's absolutely fantastic the programme has been introduced, and I really feel it will help with our succession and actually the quality of the consultants that we produce in Aneurin Bevan. So thank you for the report, and also thanks for that programme as well.
Thank you, Pippa. Paul?
Just to echo what Pippa said, really, in terms of the report, I think it's incredibly helpful and useful, and just gives us an update of all the excellent work that's been undertaken. And I'm really pleased about the apprenticeships, by the way, because I think that really does give opportunities for a range of people to come and work in the organisation. It's a huge employer in Gwent, and I think got a very good record of supporting people through particular stages, etc. But I think probably the one thing that I picked up, which I think perhaps we need to emphasise, is this important message about the third wave and its challenges, and also to ensure that we do all we can to support our staff, which I know we are doing, but thank our staff for all the work that they have done. We're still going through the COVID-19. I think there is a tendency from the media to think, oh, it's all over now, we can all go on holiday, but you can't go out, it's got to be staycation. All the sort of messages are becoming very mixed. One thing I picked up, Judith, which I think is incredibly important, is we are still dealing with the third wave COVID-19, and therefore our staff are at maximum capacity to try and deal with this issue. And therefore, for the public and the community to be aware, it's not work as normal as such. There's still huge sort of responsibilities for staff when they are seeing patients, etc. So I think that may be something we need to just think about, particularly with some of the media stuff that's coming out, sort of saying, well, it's all over now and go on holiday, but you can't fly there, you're there and everywhere at the moment because of different amber, green and red issues. But I'm not sure that the sort of the newspapers and stuff have really taken on board that there's still a big issue, that we need to support people over COVID-19.
Did you want to add something, Judith?
Yeah, I just wanted to thank Paul for his comment, but also it reminds me that I should have said that clearly we and the whole organisation feels the weight of public expectation about returning to normal. Yes. we just can't meet that expectation at the moment because of the demands on the system and the way we have to work. So I think it's a really good point, Paul. I think generally, and I understand this completely, the marker of whether the NHS is under pressure or not is purely determined by the number of COVID-19 positive patients in our hospitals or in our intensive care unit. And for the third wave, that's not the right indicator. There are so many different ways this is now manifesting in terms of pressure in our services and across our services. And clearly, if people are not sick enough to need to be admitted to hospital, they still will be unwell and need maybe access to primary care, access to community support, maybe go into ED to get some help and support. So the system will still be responding, even if people are not ill enough to need admission to hospital. So I just wanted to add that. So thank you for reminding me to say that. Thank you.
Thank you, Judith. I think that was clearly put. Sarah, did you want to add to that?
If I may, please, Chair. So, in terms of the epidemiology of the third wave, and linking to what the news and the media are reporting, so we are seeing a reduction in positive cases in the community, but it does align to when the schools were closed and schools were doing regular testing. So we are at this point not sure whether it is an actual reduction or whether it's just a reduction in people testing. And the real measure is going to be what happens to hospital admissions in terms of certainty. And we are not there yet in terms of knowing how big this peak is going to be. And we are already seeing a bigger proportion of patients who are admitted actually being admitted to ITU. Is a different patient mix, in part, or large part reflecting it's largely a younger population. But I'm afraid I'm back in my head of gloom mode because you board members will have heard talk in the media of RSV, respiratory syncytial virus, and in Australia they had a big wave that started in their summer and following the fact that the previous winter children hadn't been exposed, and we've been preparing for that, and actually it looks like it has started, and that makes very young children very sick, but it can actually also make adults and frail adults in particular very sick as well. And then again in the media there was a report from the Academy of Medical Sciences about the combined impact of COVID, RSV and flu. And looking at that report, in some ways the good case scenario is that we have a peak in flu this summer because it will boost people's immunity while we've got all of the things in our favour around summer. Or alternatively, we don't have a peak in the summer and we have a peak that's probably double the size of normal at the normal time. So the combined impact of respiratory viral infection starting now over the autumn and winter months is going to be quite considerable. And I think that's the bit that perhaps is not understood. Just counting patients in ITU with COVID doesn't give any indication of the pressure on the urgent care system. And I'm afraid it does feel like we've got another big wave of infectious disease to cope with that will be COVID plus. And it's because people weren't exposed last winter. As the restrictions on mixing are lifted, people will be exposed. And the uncertainty is how much people's immunity has dropped.
Thank you, Sarah. That's very helpful and a very excellent warning to us all. Atish?
Thank you, Chair. Away from COVID, just on the report, thank you for the report. It's excellent, and there are a number of things that I'd love to discuss, but time's short. So if I can just focus on the apprenticeships, I'm absolutely delighted about that. Absolutely consistent with the commitments that we have been voicing for some time in each of the public service boards around employment and so on, but also fundamentally, quite apart from feeding into our own workforce, fundamentally endorses our approach to supporting the tackling of health inequalities through socioeconomic differences. So I really hope that we have a fantastic cohort that come through this process, contribute to our workforce, and that they get an awful lot out of it and contribute to the communities as well. So thank you and well done.
Thank you, Tish. And we would all endorse those comments. Is there anything further? If not, thanks to Judith and the team for the excellent work they're continuing to undertake on our behalf. The key matters from committees, if we just take the committee assurance reports for May, are there any comments or issues arising from these? No? Okay. The WISC briefing. No. Any issues? I think we're about to get the update on year one of the South Wales Major Trauma Network, aren't we, Judith?
It'll be September, so it'll, yes, it launched September last year, so it'll be September. Good. This year, yeah.
Great. Okay, so we look forward to receiving that at our next meeting. EASC. Anything on EASC? I just wondered where this piece of work relates to the other pieces of work that are going on in terms of emergency and ambulance services. So perhaps we might take that up outside the meeting to make sure that we're all aware of the pieces of work that are going on, because there's a great deal of emphasis on this at the moment. Thank you. There's nothing further. Could I just thank you very much for your attendance today? And could I formally record that Geraint, our Workforce and OD Executive Director, is retiring. We wished him a fond farewell last week, and we hope he has a lovely retirement, although it sounds like he's got to do a lot of plastering and painting to me. And to record our thanks to him, and also to Chris Coley, our Special Advisor on Finance, who has retired now, and they will both be very missed. So thank you very much. We will convene for our confidential meeting in 10 minutes, if that will suit. Yep. Okay. Thank you.